until sa hanggang sa pagtrabaho nyo kung kayo ay mag-aaral at magtatrabaho sa ICU. So anyway, nakita nyo naman ang scores nyo. But to tell you the truth, it is only section 1 who got the score of 77. Si Alegre yun, di ba? Alegre, 77 ba yun? O 67? Okay, yung 77. And yung ibang section, hindi nakakuha ng line of 7. So, sobrang hindi maganda ang output para sa akin. Kasi kung nag-explain ako, tinatanong ko naman kung naintindihan o hindi. Pero parang unti lang talaga sa inyo ang nakaka-absorb sa mga iyon. And take note, kahit sa finals, pasok pa rin ang mga physiology na yan sa mga emergency situations. Okay? Marami pa rin siyang mga topic na kasama sa emergency topic. Okay, so this time, start na tayo sa emergency nursing. Dapat guys, maging seryoso na kayo sa nyo kasi magbo-board exam kayo eh. Pero parang nakita ko, hindi pa talaga kayo handa. Kailangan ayusin nyo na yan ha. 4th year na kayo. Okay. So this time, we will be discussing more about emergency nursing from this day on up to the finals. Ang finals natin is around December 11 something, 11 onwards. So maiksing panahon na lang. Okay, now in here we're going to discuss about principles of emergency nursing, assessment and intervention, airway obstruction, hemorrhage, hypovolemic shock, cardiac arrest, cardiopulmonary resuscitation, and many other things. Now, why nandito pa rin ulit yung mga shock na yan? Kasi yan po ang i-encounter nyo when we talk about emergency nursing. And these are the common. Ito yung pinaka-common na emergency na encounter ng mga ER nurses. Okay? So what are you going to learn? You will learn about emergency care as a collaborative, holistic approach. Collaborative. So hindi lang ikaw ang nagre-respond dyan, pero meron pang ibang members of the healthcare team. It's not only the nurses and the doctor, but there should be other allied health personnel na kasali sa inyo. And of course, it should be a holistic approach kasi we will be talking about the patient, the whole lot of the patient's condition, the family, and the significant others. So the priority of emergency measures instituted for the patient with emergency condition. Ano ba talaga ang priority natin when we talk about, what do you call this? Emergency measures. And then, the emergency management of patient with intra-abdominal injuries. Kasi, alam natin na kapag intra-abdominal, may bleeding. So, hindi natin alam saan ang bleeding. If that is a huge kind of injury or things like that, saan nanggaling yung bleeding, hindi natin alam. And it's just a matter of time na pwede natin i-save si patient. Otherwise, hindi na talaga siya masalba. So, it's also considered as emergency. The priority of care for the patient with multiple injuries. Isa din yan ang tatalakayin. And knowing about emergency situation, you also have to compare and contrast the emergency management of patient with different kinds of emergency conditions. Kasama na si heat stroke, frostbite, and hypothermia. Tricia, readmission slip ha. Napuputol ang lecture natin kasi bumabalik ako sa screen para i-admit kayo. Nandun na ako sa lecture, bumabalik ulit ako. Okay, what else are we going to learn? Specify the similarities and differences of the emergency management of patient with swallowed or inhaled poison, skin contamination, and food poisoning. So these are considered emergency dahil oras lang bago ma-poison na lahat ang dugo ng pasyente. So oras or minuto lang ang inaantay, depende kung kailan siya na-poison at anong oras siya dumating sa hospital. Emergency management of patient with drug overdose and acute alcohol intoxication will also be discussed. The significance of crisis intervention sa mga rape victims and the difference between the emergency care and patients who are overactive, those who are violent and depressed. Now, and also suicidal. So, hindi ito matatakel ngayon buo, okay? But this objective is the whole lot of the emergency nursing. Okay? So, hindi ito yung lahat ngayon natin i-discuss. Pero part siya. So, from time to time, kapag nag-discuss tayo, yun ang gagawin. Okay? So, talking about emergency nursing, talking about emergency nursing, so it is understood that the focus of the nurses is to deal patients with conditions that really necessitate immediate care or immediate interaction. Yung wala ka ng oras masayang. Hindi mo dapat isayang ang oras dahil kailangan talaga tulungan si patient. Okay? Now, this is for one goal is for you to prevent further damage or progression of the condition or death. Okay? Kasi syempre, dumating siya sa ER, meron na siyang injury, meron nang nangyari. Okay? So, anong gagawin mo? Are you going to waste time para maging irreversible na ang lahat ng condition? So, immediately we have to act. Okay? Kaya nga ang tawag dyan is emergency nursing. So, for definition, it is defined as a condition determined clinically or considered by the patient and his relatives as requiring urgent medical services. Kung hindi natin ayusin, kung hindi natin asikasuhin, it could result to loss of life or limb. This is what the World Health Organization defined emergency nursing. Now, meron siyang classification kasi patient or clinically and considered by patients and his her relatives. Now, in every situation, kapag may dugo, ang alam talaga ng mga pasyente at ng relatives ay emergency, lalo na kapag dugo sa ulo, dugo sa like for example, kumain ka ng dugo, umihi ka ng dugo, yung mga sumuka ka ng dugo, sa kanila emergency na talaga yun. Pero for nurses, knowing kung ano talaga ang etiology nun, we can even classify it as hindi naman talaga as emergency. Okay? So, you have to be ready to treat many kinds of illness or injury situations when you are in the emergency unit or emergency tawag nito, emergency department. Now, this one also, it is considered as emergency because it is considered yung mga critical chuchu, mga critical needs, critical na pangangailangan ni patient is also considered as emergency. Kaya again, management or emergency management is traditionally referred to care given to patients with urgent and critical needs. So kahit nasa ICU, critical patient na yan, pero in some instances, nagiging emergency pa rin. So hindi pa rin talaga kailangan i-waste ang time. Kailangan pa rin na actionan ka agad. Kahit na sabihin mo, nandyan ka, every 15 minutes ang monitor mo and things like that. But still, meron pa rin instances na emergency pa rin. Okay? Now, there are, di ba sabi ko, meron tayong classified as clinical and yung perceived by relatives and patients. So ito na yun, emergency nga yan, pero non-urgent. Okay? Lalo na yung mga dahilan na ito. Number one, people lack access to healthcare. So usually talaga yung mga galing ng probinsya, papunta ng city. So ang alam nila na kapag may mga problema and things like that, diretso sila sa emergency department. Okay? Kasi yun lang ang alam nila ng portal of entry papunta sa hospital. Pero depende kung ano ang kondisyon nila. Now, meron naman talaga kondisyon galing province hanggang hospital ng city is emergency talaga. Pero meron hindi. Okay? It's the reason why kaya yung sinasabi nila there is a lack of access to healthcare kaya yung people na mga remote area pumupunta sa city ED kaagad, emergency department kaagad. Okay, next. People's understanding that ED is the way to get access to healthcare personnel from which they perceive that their problem and conditions are addressed immediately. So yun lang, pagkaalam nila, ang emergency department, any problem mo, kahit mataas ang lagnat, sige, pasok ka doon. Okay? Yung ganon. Kaya, ang sabi niya, the philosophy of emergency management has broadened to include the concept that an emergency is whatever the patient and family considers it to be. Kung sa kanila ay emergency, hindi natin siya, kumbaga, tawag nito, hindi natin siya deadmahin. Asikasuhin pa rin natin. But the thing is, kapag nasa ER na, in a certain situation, kaya ang daming mga dyan, ang daming mga clashing, ang daming mga nagwawala. Kasi feeling ng relative, emergency na yung condition ng relatives ng pasyente. Pero sa assessment ng nurses, hindi siya as number one or emergent na sinasabi natin. Meron pang mas emergent na kailangan natin aasikasuhin. Pero kung walang ibang pasyente sa ER, syempre sila ang uunahin. Kasi meron ganun eh. Nauna kami dito, bakit iyan ang inasakaso kung magkararating lang? Yung mga ganun, di ba? Nandito ka na, bakit iniwan mo kami? Pumunta ka dyan. Mas nauna kami dumating sa kanya. Ganun ang mga pag-iisip nila. Pero hindi nila alam na we are dealing with life and we are battling with time. Okay? So, ayun. Now for this, meron tayong mga principles of emergency care by definition. Ito na nga ang kailangan. Hindi tayo kailangan mag-delay sa mga action natin kasi it is considered as emergent. Okay? Now, ang sabi, kagaya ng diniscuss ko kanina, several patients with diverse health problems, some life-threatening, some not, may present to the ED simultaneously. So it is the skill of the nurses who is going to attend this patient and to make them understand who is the priority of your care. Okay? Because your goal is to preserve life and prevent further injuries. Okay? Yung promote recovery, continuity of care na yan sa ward. Pero still, ikaw pa rin ang, kumbaga, maglilid kasi ikaw ang ER nurses. So, anong gagawin? Kapag na-resolve na ang emergent condition ni patient, na-prevent mo na yung further injury, endorse mo na yan sa ward. Okay, yan na yung sasabihin mo na, what do you call this? Ang sasabihin mo na, okay, ito na ang ginawa, itong ganyan, so ganito, so for further siya. So this is, kumbaga, yung initial para sa pag-promote ng recovery. Okay? Now, let's talk about the principles of emergency care. One is anticipation. Si emergency nurse, dapat talaga is well knowledgeable about emergency situations, about the condition of the patients, kung anong itsura niya. Kasi isang tingin mo pa lang, alam mo na kung ano ang mangyayari. Ganun yun. Isang mo pa lang, isang information lang marinig mo. May dadating dito, may dadating dyan na pasyente, galing sa ganitong aksidente. Meron siyang head injury, meron siyang ganito. Tatanong mo yan, anong oras nangyari ang aksidente? Sinabi, mga nakalipas na 15 minutes na on the way na kami, by 10 minutes nandyan na kami, mga ganon. So alam mo, pagdating sa hospital, 50-50 na si patient. Pero kung ambulance ang nagdala sa kanya at may EMT, alam niyo yung EMT. Kapag may EMT, so baka makakasurvive pa si patient. Pero kapag walang EMT at basta na lang dinala sa pasyente at alam mo kung anong minuto na, anong oras na, baka 50-50 na si patient. But still, we still have to do the thing. Okay? We still have to act upon the condition of the patient. Anticipate na tayo. Naku, 15 minutes na nakalipas, tapos dadating siya. Diyos ko, dahil, sige, sana mabilis sila dumating kasi ano. So pagdating pa lang, abang ka na, nakaabang na yung bed niya, minsan yung stretcher, diretso na yun, nagiging bed, nakaabang ng oxygen, ilagay na, nakaabang na lahat-lahat, pati mga IV, abang na sa kanya. Okay? Another one is the teamwork. In an emergency situation, you cannot work alone. You really need help. But what is good thing in teamwork in the emergency department is that kahit hindi mo sasabihin, alam mo na alam ng kasama mo ano ang kasunod na action ang gagawin. So habang ginagawa mo pa yung isang action, nag-work na siya or sila para sa next action and things like that. So you are working in one patient simultaneously and subsequently yung mga tawag nito, mga interventions na dapat ibigay. So that is a good teamwork. At saka walang ingayan sila. Alam kasi nila ang ginagawa nila. Okay? Maliban lang kung talagang toxic ang pasyente na nagsi-CPR na kayo and then nandiyan na si doctor and many things, syempre may mga kunting ingayan dahil sa mga orders ni doctor and things like that. But otherwise, hindi naman yan palengke. Now, in some cases also, kapag ganyan, alam natin na ang ER ay pwede maging palengke. Sobrang ingay, sobrang kasi nandiyan ang mga relatives, hysterical and things like that. But other members of the team in the ER will pacify them. Okay? Ito yung mga nurse na nag-face ng gumagawa ng crisis intervention for the family. Okay? So we'll talk more about teamwork kapag we go along with our topic. Then, inappropriate and frequent attendance at the emergency department. Itong mga inappropriate and frequent attendance, ibig sabihin nito, ito yung mga, what do you call this? Mga pasyente pumupunta doon dahil lang minsan masakit ang katawan, hindi nakatulog, yung mga ganyan. So, pumupunta sila sa ER. ER talaga, hindi clinic, ER. Meron naman iba na pumupunta dyan kasi kakilala yung doktor. So, papacheck up. So, doon pupunta sa ER. Yung mga ganon. This is what we mean inappropriate and frequent attendance at the emergency department. So, bakit nandito siya sa principles of emergency care? Kasi, hindi natin maiwasan talagang sa ER kung sino-sinong pasyente ang dadating. So ito yung mga classifications. Now, bakit nandito to is that for you to understand and to learn how to deal with it. Okay? Paano mo i-deal pag ganito? Okay? Anong gagawin mo? Deadbahin mo ba? Paalisin mo ba? Yung mga ganyang bagay. So, pasyente pa din yan. Okay? So, welcome mo pa rin siya. Pero alam mo ang mga priorities mo. Diba? Okay. The same way as the frequent attenders, ganun din yun. Now, kahit pa paano man, as a nurse sa ER, pag may mga dumating ganyan, huwag naman kayong magsimangot. Okay? Bakit? Isipin nyo, lalo na if you are working in a private hospital. The private hospital sustained because of the patient. Nabubuhay yan dahil sa mga pasyente. Binibigyan kayo ng sahod dahil sa mga pasyente. Tapos ayan kayo, ayan na naman, may pasyente na naman, hindi na ako nakakapagpahinga, nakakainis naman to. Huwag naman ganun. Lalabas ang swerte nyo. So, kailangan pa-welcome pa rin. Ay, salamat. Magiging on time lagi ang sahod namin kapag ganito kadami ang mga pasyente. Baka may incentives pa kami. Dapat ganun ang isip natin, di ba? Kung ano ba yan? Sana walang pasyente kasi para makapagpahinga naman ako, mga ganon-ganon. Huwag naman. Okay? Kasi nandyan tayo pasalamat tayo. Blessings yan kapag may pasyente. Okay, injury prevention. Okay, kagaya ng sinabi ko kanina, that is your goal. Prevent further injury. So, hindi ko na-discuss yan dahil alam mo, kapag injury prevention, action kagad. And kailangan may kaakibat pa yan. Critical thinking and decision making. So, kailangan sharp ang pagka-critical thinking mo, kaya you enhance that skill and enhance the decision-making skills. Then another one is a notifiable disease. Ano naman ito? Notifiable disease. Yes, meron tayong ganyan. So these are infectious disease that happens in certain area na pag pumupunta sa'yo, titignan, uy, first time to merong ganito ah. Ano kaya ito? Siyempre, hindi mo pa alam kasi infectious. Pero nakita mo, may coryza siya, namumula talaga ang ilong, tapos ang init, tapos nung tinanong mo, yung mga etiology niyan, sabi mo, aba, first time to ngayon ko lang na-encounter to. But this one is not yet notifiable kasi isa pa lang. Okay? But the uniqueness of the condition, pwede siya maging notifiable. And the following or in the evening, may dumating pasyente ganun naman. In the morning, kinabukasan, may dumating ganun naman. Okay, kailangan i-track mo na yan. If you are the leader in the emergency department, kailangan i-track mo na yan. Aba, pare-pareha sa mga sintomas nila. Tignan nga natin saan ba nanggagaling ang mga ito. So check nyo ngayon ang mga background. Check nyo ngayon ang mga address nila. I-plot nyo yan. And then kung makita nyo na nasa isang lugar na lang sila, report ka agad sa Department of Health. Okay? So yung pag-report sa Department of Health, may proseso yan. So alamin ang proseso ng ER o ng hospital nyo kung paano ang pag-report sa Department of Health. Kasi itong si Department of Health, i-assess niya din yan at i-check niya din yan sa ibang hospital na malapit doon sa area kung saan mo ni-report na merong ganitong klaseng mga sintomas sa isang lugar lang. Okay? And that's the time gumagawa na sila ng mga epidemiological studies about the signs and symptoms. And then i-announce na nila yan. Mag-precaution muna tayo kasi meron tayong outbreak ng ganito-ganito sa area na yan. Okay, sometimes i-isolate pa yung area na yan. Okay? Another one is patients with disabilities. Now, alam naman natin na ang patient with disabilities ay itong mga may priority. May priority sila sa mga grocery stores, may priority sila sa sinehan, may priority sila sa jeep, sa mga sasakyan, sa lahat ng bagay, may priority sila. Okay? Pagdating sa hospital, may priority din kaya sila. Now, it depends kung ano ang situation nila, kung ano ang condition nila na pwede natin sila gawing priority. Okay? So, iyon. That is about the condition. So, another thing about patients with disability is that some of them have cognitive impairment. Okay? And that is a challenge to the nurse dahil mahihirapan siya kumuha ng data dahil si patient hindi masyado makaintindi sa mga tanong, hindi masyado maka-explain yung mga non at hindi naalala kung anong nangyari sa kanya. Many things about cognitive conditions. Okay? So challenge yan. Lalo na kapag yung nagdala sa kanya ay hindi kilala. So as much as possible, treat muna kung ano yung dapat i-treat sa kanya as emergency. And then afterward, continue, check kung ano bang background nito, saan, and things like that. Okay? Yan ang challenge natin sa mga patients with disabilities. Pero when it comes to yung physical disability lang, depende sa kondisyon nila na pwede mo sila gawing priority. Ang pinaka-priority natin ay buhay. Okay? Na tigok-tigok na pwede pa isalba. So yun yung pinaka-priority natin. So kung hindi naman silang tigok-tigok na na pumupunta lang diyan dahil sa like sobrang sakit ng ulo o kaya nabali ang buto. So hindi pa rin yun pwede considered as emergency dahil ang pinaka-emergency natin ay yung isang pasyente sa tabi na tigok-tigok. Pero kung walang ibang pasyente sa ER, syempre sila na ang uunahin natin. Okay? Mga not really as emergent. Sila na ang unahin dahil wala naman emergent dumating. Okay? Next is triage. Now, triaging is classifying patients according to emergency conditions. So we will discuss that more. Okay? Now, ito, na-discuss ko na lahat, pero ito ay mga explanation lang. Pero pupunta tayo doon sa triage. Okay. So, ang triage, ibig sabihin lang yan sa French is to sort out or to sort. So, by the next semester, meron na kayong disaster nursing, part din yan is triaging, okay? So, at least meron na kayong idea kung paano ang pag-triage. And nakita ko naman na in some hospitals, meron silang triage area. And sometimes, ina-assign kayo sa triage. But the triage na sinasabi natin is different, okay? Because parang nakikita ko dito sa mga hospitals is kukuha ka lang ng vital signs and then record and then dadalhin sa loob para ng pasyente. Pero when it comes to patients search, okay, yung search, S-U-R-G-E, okay, search, kailangan talaga natin i-classify sila in different categories. Ito yung emergent, urgent, and non-urgent. Okay? So, ayan. So, talking about triage, when we say emergent, these are the patients who have highest priority. Talagang life-threatening na hindi ka na dapat magsayang ng oras, asikasuhin mo na kaagad siya. And the urgent patient are those patients with serious health problems pero hindi life-threatening. Okay? Na pwede pa antayin kahit sabihin natin 30 minutes pag natapos natin dun sa isa, ito na. Ito ang susunod. Okay? But again, yung patient with serious health problems, tignan niyo muna baka may certain kind of bleeding, yung isang oras mahaba na yan o 30 minutes mahaba na yan na baka nag-bleed sa loob. Okay? So, assess niyo maigi. Okay, those? And the non-urgent are patients who have episodic illness that can be addressed within 24 hours without increased morbidity. Punta-punta lang. Dapat nga yung non-urgent sa clinic lang. Sa clinic na lang sila pupunta. Kaso nga lang, sa clinic, iba kasi ang set up dito sa atin. Kasi ang clinic natin ay more on follow-up check-up. Yung mga pasyente pumupunta dyan ay yung mga pasyente na galing sa iba-ibang araw ng admission na pinapa-appointment kaya bumabalik sa clinic. Ganun yung setup natin. Pero wala tayong clinic na yung talaga yung papunta dyan para magpa-check up. Pero alam ko, meron tayong may sistema tayo niyan. Ang sistema dito sa sa Manila may sa ospital ng Maynila, inaano sila sa OPD. Malaki talaga ang OPD nila at saka doon dumadaan yung mga pasyente na walang appointment na yung pupunta lang dyan na hindi urgent ang mga sakit. Okay? Sa OPD sila pumupunta. Dito sa atin, ewan ko, kasi meron bang OPD ang mga hospital na nagjo-duty kayo? Kasi parang considered siya as anong tawag nito, yung specialty in patients, client. Well, anyway, ang classification dyan is based sa condition ni patient, okay? So the fourth category is increasingly used as fast track, okay? Ito yung mga pasyente na kailangan ng first aid and then after that, i-refer na siya sa ibang department or ibang clinic, okay? Yun. Yung for example, na aksidente sa bike na ang laki ng na punit yung ugat. So, pagpunta dyan, fast track lang, stop the bleeding. Okay? After stopping the bleeding, send to the clinic. Okay? Kasi si clinic na ang titingin sa kanya at magbubook ng second appointment para to make sure na walang nangyayaring infection and things like that, na okay lang si patient, and maraming bang bagay. Okay? So, ayan. Next. Okay, so the triage system na sinasabi natin ay meron talagang 5 levels. We have the resuscitation, emergent, urgent, non-urgent, and minor. Kumbaga yung non-urgent and minor pwede isahan na lang, pero may kaibahan pa kasi eh. Okay, may kaibahan. Like for example, anong example ng minor? Ito yung like hindi nakakatulog, ganon, or laging sumasakit ang balakang, or sumasakit ang tawag nito, ang tiyan, pero depende pwede ilipat masakit ang tiyan sa non-urgent instead of minor. Okay? Another example of minor, yung cuts, yung mga sugat, yung mga natumba, kailangan lang ng dressing, or kailangan ng na spray, na kailangan ng sementuhan, yung mga ganyan. Now, sa mga urgent, yun na yun, yung umiiyak, non-urgent, umiiyak dahil ang sakit ng ulo, okay? Ibig sabihin yun, consider mo ba emergency? Yet, remember guys, ang mga tao, meron yan different threshold sa pain. So yung isa, kahit nasa number 5 lang, out of 1 to 10, overacting na talaga. So you really would have to assess kung ano ba talaga ang totoong condition ni patient. If the patient is in pain, okay, na sabihin natin nasa 9 or 10, syempre iiyak talaga yan. Pero check the pulse rate, check the respiration, check everything. Pag mataas yan, totoong may pain siya. Pero pag iyak-iyak lang, pero normal naman ang pulse rate, hindi totoo yun. Okay? So, ayan lang. So, patients in the emergent category identified in the previously used 3-level system have been divided into 2 distinct groupings. Okay? So, yung emergent, yung sinasabi natin kanina, okay, mas clinafsify pa siya ng dalawa. Yung isa, yung resuscitation, yung CPR na kagad. Yung isa is emergency talaga. Okay? So patients in the resuscitation category needs treatment immediately to prevent death. Okay. After you have assessed the patient and naayos mo na ang triaging and things like that, and action is taken to implement para ma-prevent further injury, para ma-save si patient, this has to be immediately transported to the specific department. Like for example, galing sa aksidente, okay, naggumawa na ng bagay ng immediately, mga resuscitation para ma-stabilize. After that, transfer ka agad sa operating room para hanapin kung ano ang cause ng bleeding doon sa loob ng katawan niya, things like that. Or transfer ka agad sa ICU para meron na siyang monitoring kasi insertan pa siya ng catheter, yung mga subclavian catheter and things like that to hemodynamically assess the internal parameters of this patient. Kasi kung BP lang tayo, patay tayo dyan. Kailangan alamin yung anong nangyari sa physiology sa loob. Okay, dokes? So, ito yung mga priority natin. Now, let's talk about assessment of a patient who is in an emergency condition. May question sa principles? May question kayo?
Ano po?
Andyan pa ba kayo? Si Jancel lang sumagot.
Nandito po, ma'am.
Yes po.
Okay. From time to time, tatawag ako. So, kung hindi kayo sasagot, absent yan. Ibig sabihin, naka-login lang kayo. Okay? So, start na tayo. Assessment and intervention. Okay, now in an emergency situation, meron tayong sinasabing primary and secondary survey. Okay, so ang primary survey natin is yung kailangan talaga kung anong nakita natin kay patient pagkadating sa emergency room, kung ano yung condition niya. Siyempre malalaman nyo yan, di ba? Kapag life-threatening siya. So, kailangan talaga, you really have to make sure na ma-stabilize mo ang A, B, C, D. Okay? And to assess that, you have to learn about A, B, C, D, E. Okay? So, ano yun? A, B, C, D, E. Airway, breathing, circulation, disability, exposure, or environment. Saan nangyari yan? Paano nangyari at chuchu? Okay? So, ayan. So, habang dumadating, tinatransport ang, tawag nito, ang stretcher, papunta na doon sa area na saan may bed, emergency bed. Okay? So, lahat-lahat na tinitingnan mo, ay naku, ano siya? Ay naku, tachycardic yata. To, tignan natin. So, check na kaagad. Ilatag na kaagad ang monitoring machine, pati yung BP, yung probe para sa temperature, para sa pulse oximeter, lahat na at one time, ma-check mo. And then habang chine-check yan, ask mo na, paano nangyari, ano. So doon, kuha mo na kaagad. Within 1 minute, wala pa, hindi pa matapos ang 1 minute. Or exactly 1 minute, makuha mo na lahat simultaneously ang information na yan. Bakit? A, B, C, D. Okay? A, B, C pa lang. Okay? A, B, C. Ang D, ma-observe mo yan sa kanya. Ano ba ibig sabihin ng disability dito? Ito yung mga condition ni patient, kung pwede pa ba siya magsalita, kung conscious ba siya, kung unconscious, and things like that. So, at one look lang, makita mo na yan, di ba? Ang A, B, C, isang salpak mo lang ng machine yan, and the machine will give you the whole lot of information. Like for example, ang oxygen saturation, magbibigay na yan si machine. Kapag inalagay mo yung probe sa kamay niya, yung BP, yung pulse, yung temperature, makukuha kagad yan ni machine. Okay? And then yung mga perfusion dyan, makikita mo naman sa mukha, sa mata, or sorry, sa physical appearance niya. Wait lang, kasi lobat na ako. Connect ko lang sa kuryente. Okay. So makikita mo lang yan. So within 1 minute, tapos mo na yung primary survey. Okay? Now, if for example, the patient comes in na nakita mo, tigok-tigok, Okay? Kagad, action na. Okay? At saka hindi lang ikaw yan. Marami kang kasama sa ER. Usually in ER, may mga 5, depende sa laki ng ER. 1 bed is 1 nurse. Okay? Pero kung ano naman, 1 or 2 bed is for 1 nurse. Yung mga ganyan. Pero talagang meron sila yan extra kasi in case of emergency, kailangan talaga. May mga extra nurses yan talaga dyan. Okay? So, if for example, nakita nyo yung airway niya, yung paghinga niya hirap, you really have to establish the airway. Provide adequate ventilation. Now, if for example, kailangan na niya ng ET tube. So, prepare mo na kagad ng ET tube and then contact na kagad. Somebody will have to contact the anesthesiologist para makapag-insert ng endotracheal tube. But, most of the ER nurses and doctors are trained. Now, dito sa atin, hindi. Okay? Only doctors can insert endotracheal tube. Mga nurses hindi. But in some parts of the world, like the US, Canada, UK, train ang ER nurses to do that. Okay? They allow ER nurses pero dapat certified. Yung mga ganyan. Okay? And then after you establish the airway, check mo ang cardiac output niya. Okay? If for example, ano bang case ng pasyente na to? Naku, patay tayo. Ilang minutes na natira, nalipas. So, ang dami na nitong dugo lumabas. Yun ang expect mo. So, i-expect mo ngayon, hypovolemia na siya. So, gumawa na ng paraan para ma-survive si patient. Okay? So, one thing there is control the hemorrhage. Saan banda yung sugat? Saan banda yung saan banda yung origin ng hemorrhage. Okay? And then after that, ano ba ang gagawin para ma-stop yung hemorrhage? Di gawin mo na. And after that, anong gagawin to treat hypovolemic siya? Gawin mo na. Okay, alam naman natin na talagang fluid resuscitation dapat. So, anong klaseng fluid ang ibibigay mo? Okay? And maintain and restoring effective circulation. So, kailangan kung wala namang mga other problems si patient, not in bed siya para proper ang circulation, balance lang. And of course, another thing, these include the prevention and management of hypothermia. Remember, ang ER natin, okay lang ang ER natin sa Pilipinas, mainit. Okay, sa ibang bansa, sa ibang mga lugar, ang ER naka-aircon pa din. And this can immediately, kasi in shock si patient, this can immediately, affect the patient. But not as emergent. Ang pinaka-emergent is A and B and C. Okay? And after that, manage na ang hypothermia. So, in addition, peripheral pulses also can be examined kasi malalaman natin kung properly perfused ba yung mga distal joints niya, distal bones niya, or distal extremities niya, particularly if may aksidenteng nangyari na nagkaroon ng broken bones, okay, or fractured, okay, or anything that can impede the circulation distal to the core body, distal to the main body. Like for example, mga paa, mga daliri sa paa, mga ankle, and things like that. Okay? Now, yung disability na sinasabi ko, yun na yun, mga level of consciousness and things like that. Okay? Okay? So, using the GCS na very expert na kayo gumamit, and that is very good. Okay? Expert na kayo dyan. So, madali nyo na i-determine kung ano ang status ni patient. Okay? Kung anong level siya. Okay? Then, after that, you already have finished all the emergency conditions na emergency actions na dapat gawin. Kumbaga, kung ano ka na yung medyo kalmado ka na dahil na-meet mo na yung emergent situation. Okay? But it doesn't stop there. Ang assessment mo, continue pa din after that. And this is what we call the secondary assessment. Okay? So ito na yung head to toe. So ito naman, pwede ito matapos hanggang bago, bago lumipat si patient sa ward, bago lumipat si patient sa area kung saan, or endorse mo ang mga hindi mo natapos. Okay? So here we have diagnostic and laboratory testing. Sometimes hindi ginawa mo na yan. Sometimes doon pa lang sa primary survey, at the same time kinukuha mo na yung mga laboratory test. Pero bago lumipat si patient sa ibang department, hindi pa dumadating ang laboratory. But still, empirically, ibig sabihin, based on previous mga experience nyo to deal with this kind of patient, alam mo kung gaano ka life-threatened ang condition ni patient. So, itong mga laboratory na ginawa mo, parang basis na lang yan. Parang, kasi first laboratory yan ng pasyente the moment na i-arrive in the ER. So, parang basis mo yan in the future. Okay? Another thing, insertion and application of monitoring device such as the ECG electrodes, arterial lines, and urinary catheters. Okay. But still, ang secondary survey, itong mga insertion, nagawa na to sa primary, nasa phase ka pa lang ng primary, nagawa na yan. So ano naman ang role ngayon na sa secondary survey? Ano naman ang role ngayon tapos na yung insertion? Ang mangyayari dyan, i-monitor mo. Okay? On-site ba ang mga area, ang mga ano na yan? O kumusta na ang mga readings dyan? Okay? Yung urine output niya after resuscitation, okay ba? Bumabalik na ba sa normal? Mga ganung bagay. Okay? And splinting of suspected fractures. Ito na yun, natatawag ka na ng ng ortho, ang tawag nun? Orthopedic, yung gumagawa ng mga simento, yung ganyan. Nakalimutan ko ang pangalan niya. May pangalan yan sila eh. Okay? Kasi kapag ano naman, ano pangalan niya na wala talaga sa utak ko. Anyway, so, ayan. Yung mga arterial lines, check mo na kung tama ba talaga. Every 15 minutes naman kasi yan. Okay? And then, cleansing, closure, and dressing of wounds. So, ready na kasi for si patient for transport. Ayan na, ayusin mo na siya bago mo i-transport. And performance on other necessary intervention based on patient's condition. Okay? Okay, so dito meron tayong guide kung ano ang gagawin mo kapag primary assessment. We have the ABCDE. Okay, secondary assessment, full head-to-toe assessment, including vital signs, including para mga parameters nila. Then, by the time na dumating na si patient sa tawag nito, time na medyo stable na, ready na for pwede ka pa to complete some of these assessment na nakalinya dyan. Okay? Now, kaya ang guide natin is A, B, C, D, E, F, G, H, I. Okay? F, full set of vital signs, focus adjuncts, like for example, yung mga monitoring natin. Okay? And then, facilitate family presence kasi medyo na siya, na survive na, medyo natapos na yung emergent condition niya. So, make the patient feel na nandyan si relatives. Okay? Bakit? Isa yun sa mga psychologically nakakatulong sa mga pasyente na to make them more to make them more parang motivated na to fight, okay? Kung ano yung condition na meron sila. Make them motivated. Kasi pag wala, pag isa siya, talagang parang dark ang mundo niya. So, isa yan sa mga isa yan sa mga focus din natin. Siyempre, di ba, alam naman natin na holistic ang nursing natin. Okay? And then, G, give comfort measures. Okay. Ano-ano mga comfort measures? Baka kanina pa nakaano si patient, baka kanina pa gusto na niyang gumalaw ang likod kasi ang sakit na ng likod niya. Resuscitate mo na, tapos kung ano-ano pang ginagawa, umabot na siya ng 3 oras sa ER, isang position lang siya, baka nangangawit na siya. Okay, so while you transport the patient, medyo pwede siya maging semi-Fowler's position kasi okay naman na siya. Tapos medyo lagyan ng unan yung tuhod or yung para maging komportable siya. And give a head-to-toe assessment. Give history and head-to-toe assessment. Madali na lang yan kasi ang head-to-toe observation madali. Pero yung sinasabi natin ng mga to check the Babinski and things like that, pwede mo yan i-insert. Pwede mo yan gawin. Para pag-endorse mo yan, sa ward or sa area kung saan siya lilipat, kompleto na ang information ibibigay mo kay patient. Pagdating kasi doon, sila, iba din silang assessment ang gagawin nila, pero continuation ng assessment mo. Yung ginawa mong assessment sa ER, uulitin pa rin ulit nila yan every 15 minutes kapag ordered as every 15 minutes or every 30 minutes as ordered. Okay? Depende. Uulitin at uulitin ulit yon. And then as another kind of assessment pa. Okay? Now, talking about another kind of assessment, ito na yung mga family history, social history, mga ganun-ganun. Okay? Ito kasing history dito, history sa ano ang nangyari sa kanya. Okay? Iyon yun. Bakit siya pumunta dyan? Mga ganun bagay. Okay, Dukes? In addition to the management of the illness or injury, the ED nurse must also focus on providing comfort and emotional support. Okay, so aside from yung position na sinasabi ko, dagdagan pa natin pain kung meron ba talaga siyang pain. Particularly patients who comes in because of chest pain, okay? Usually talaga mga sa ER, talaga mga chest pain ang mga pumupunta dyan. Pag sasakit sa ulo, hindi naman talaga. Kasi may mga pasyente talaga, kahit sobrang sakit na ulo, hindi yan pupunta sa ER. Antayin lang yan na bumaba ang sakit o kaya iinom lang yan ng over-the-counter medications. But there are some instances na yung headache is yung parang bibiyak ang ulo mo na tapos nakokollaps ka na. Ayun. Ayan, dapat talaga yan idala sa hospital. Alam mo bakit? Kasi pwedeng mangyari, meron siyang hemorrhage sa ulo. Okay? A very unusual kind of pain is a different story na. Okay? Kailangan ipa-ER mo na yan. Lalo na kapag na-collapse ang pasyente. I-CT scan ka agad yan siya. At pagkatapos i-CT scan, tignan na kung anong interventions mangyari. Magkano ngayon ang isang CT scan? Mahal na yata, di ba? 10,000. CT scan lang yun, na. Okay? So, if for example, itong pain naman is because of the fracture and things like that, okay? Because of the big injury na nakaroon siya ng malaking hiwa, okay? Bigyan natin sila ng pain reliever, okay? A rapid-acting agents that result in sedation. Bakit sedation? Bakit meron pang sedation? Kasi kailangan ni patient ma-regain yung energy niya. So medyo i-decrease natin yung activities niya. Okay? Baka mamaya because of low cardiac output, nagiging irritable siya, nagiging confused. Remember guys, kapag confused na, ibig sabihin apektado na ang brain cells. Okay? Wala nang oxygen doon. So, kapag restless si patient, the more oxygen ang gagamitin niya sa mga galaw niya. So, medyo pa-sedate muna siya. Okay? Para less ang activity niya, yung oxygen demand ng brain mapupunta sa brain. Okay? Ayun. Moderate sedation can help facilitate shoulder procedure as well. Like for example, nagtatahi ka ng malaking sugat dyan. Okay? So bigyan mo siya ng sedations. o kaya anything that involves the lungs, the pleura, for example, na aksidente na through and through yung tubo sa pleura and things like that, kailangan talaga may sedation. Okay? And the patient will not remember the procedure later. And then after that, closely monitor na lang. After sa hanggang sa paggising niya. Now, the ongoing assessment is indicated to identify the individual's response to the actions that you have given or you have taken to prevent further injury. Ay yung mga interventions mo. Kumusta? Okay na ba siya? Wala na bang bleeding and things like that? Kumusta na ang respiration niya? Kumusta na ang urine output niya? Yung mga ganang bagay. Okay? So that you will know if the patient is still in the critical condition or okay na. Okay? Na hindi naman kaagad na okay na, pero at least yung yung medyo na-alleviate na. Kunti, kumbaga, may success ka na kunti sa interventions mo. But again, on guard ka pa rin kasi baka mamaya bigla na lang ulit bumalik yung wacky na vital signs ni patient because of the ano ba ang nangyari sa kanya. Baka mamaya because of decreased cardiac output, acidotic na siya and things like that na hindi mo napansin. Dapat kasi may because of the siguro mapapansin din kasi sa vital signs kasama na ang oxygen saturation. Okay? So makikita mo ngayon kung ilan ang saturation niya. So kapag umabot na yun ng 85 or 80, i-insert ka agad yan ng endotracheal tube. Okay? After that, check the ABG, mga ganun-ganun. So doon pa lang alamin mo na sa ABG kung acidotic na ba siya o hindi. And then after that, malalaman mo kung pwede pa ba isolve ang problema ni patient or deteriorating na siya. Okay? Yung bang oras na lang ang inaantay. Next, conditions necessitating emergency interventions. So meron tayong airway obstruction, hemorrhage, hypovolemic shock, wounds, and cardiac arrest or CPR. O bakit nauna yung bakit nauna yung wounds? Mas emergent ba ang wounds? Hindi. Mas mahaba kasi ang topic ng cardiac arrest. Okay? Pero of course, si cardiac arrest ang pinaka-emergent dyan. Diba? Siya talaga ang pinaka-emergent tsaka si airway. So, ito ay topic lang, hindi ito in sequence na yun ang uunahin natin gawin. Okay? Ayun. May question?
Wala po, ma'am.
Okay. Okay, so let's move on. Talking about airway obstruction. Si airway obstruction, meron dalawang klase. Partial and complete. Okay? So, kapag partial, ibig sabihin nakakahinga pa si patient. But, if it is not removed, it can lead to progressive hypoxia, hypercarbia, and respiratory or cardiac arrest. Okay? So, kailangan talaga i-remove ang obstruction. Now, kapag naman meron complete obstruction, kailangan pa rin talaga i-remove. And usually, the intervention should be implemented within 3 to 5 minutes. Bakit? Kasi kapag lumampas pa dyan, expect nyo na ang brain cells ay wala nang nakukuhang oxygenated blood. Kasi si respiration ang nag-o-oxygenize sa mga blood. Wala complete obstruction ng respiratory system, ang airway niya. Okay, so ano mangyari? So walang air exchange mangyayari sa alveoli. So walang oxygenated blood mapupunta sa brain cells. So take note, if wala, how many minutes will it take? Within 3 to 5 minutes dapat. Pero kung wala na, mag-start na magkakaroon ng brain cell death ang mga brain cells natin. Okay? So kahit nasabihin natin na na-revive natin si patient pero unconscious, expect nyo hanggang dyan na lang siya. Kasi ang brain cells niya, marami ng namatay, marami ng necrotic, okay, necrosis. dahil walang oxygen nangyari. Yun yung sinasabi natin na mabubuhay man siya pero gulay na. Okay? Pero meron talagang, alam mo, may mga kwento talaga akong nakita na comatose for how many years, tapos nagising, yung mga ganon. Kasi alam niyo naman, meron naman tayong mga cell regeneration. But the only thing is, when you talk about our brain cells, it takes time, and sometimes it's not happening kasi because of the comorbidity, like for example, yan, nagkaroon siya ng nagiging comatose na lang siya kasi maraming brain cells ang namatay. Okay? Pero buhay pa siya because of the respirator. So buhay siya pero brain dead siya. Now, in some cases, itong mga brains kasi, mga brain cells, nagre-regenerate, pero not necessarily para mabuhay ang pasyente. Kasi it will take years talaga. It will take years. Now, sometimes, during the procedure, during the process of healing or taking care of this comatose patient, nagkakaroon pa siya ng mga comorbidities. Like, for example, imbalance ng electrolytes and things like that. So, wala talaga. Nagiging nagiging downward spiral na. Okay? So, ayan. Then, causes of airway obstruction, usually aspiration of foreign bodies, anaphylaxis of viral or bacterial infection, pwede din yung trauma, and sometimes yung pag-inhale mo ng strong chemicals. Okay? Or kung strong chemicals, pwedeng magkaroon ng chemical burns ang mga mucous membrane mo sa respiratory tract. Kaya magkakaroon ng inflammatory response. And because of that inflammatory response, hirap na hirap huminga si patient kasi namamaga ang airway passages niya. Okay? Now, if that is a foreign body, ang gagawin is the Heimlich maneuver. Okay? So, yung Heimlich maneuver sa RLE ninyo, sa 1941, di ba meron tayo 6 weeks ng August, hindi pa kayo nag-hospital. So, itong mga ito, dapat natuto nyo na noon sa 6 weeks nyo sa skills lab. Okay? So, ayun. So, isa sa mga yan is the Heimlich maneuver at saka yung mga insertion of airway. Dapat natuto nyo na yan. Natuto na kayo yan noon sa RNA nyo. Okay, what are the risk factors for older adults when it comes to airway obstruction? Sedatives and hypnotic medications, pwede. Okay, kumakain si lolo or si lolo, si patient, pero kakainom lang din niya kasi sabi dapat daw pagkagaling sa clinic o pinainom na sa kanya yung gamot. So magla-lunch na, kumakain, dumalaw yung antok. Ayun, yung kapalang kinakain niya, nilagang baka, di na choke, okay? Ayun. So kailangan talaga yan, no? Kailangan talaga tanggalin yun. Okay, diseases affecting the motor coordination, like for example, Parkinson's disease and mental dysfunctions like dementia and retardation. They are the ones very susceptible to aspiration asphyxiation of foods. Yung nagbara sa lalamunan. Okay? So yun. So ito ang mga dapat gawin kapag meron mga conditions like that. Then, abdominal thrust of Heimlich maneuver, nasabi ko na yan. And if, for example, si patient ay okay na, and siyempre may mga conditions na pumasok ang foreign body, nakokolapse si patient kasi matagal na bago matanggal yung foreign body. So, let him to lie down, and then maintain ang airway by doing the head tilt chin lift maneuver. Okay? And sometimes naman, the obstruction cannot be removed. Let the patient to lie down, open the head, position the patient, and putting the head tilt chin lift to remove the foreign body inside. Okay? Ayun. So, the airway is opened using the head tilt chin lift maneuver or the jaw thrust maneuver. So, anong difference ng dalawang ito? Si head tilt chin lift maneuver is used kapag walang cervical injury ang pasyente. Ang jaw thrust maneuver ay ginagamit kapag may suspected spine or cervical injury si patient. Okay? Yan ang difference ng dalawa. Okay? So watch this video for that.
Hello friends, today we're going to see about jaw lift and chin up position. Before going to the video, if you're new to my channel, please subscribe to my channel and click the button to get regular notifications. Now we'll get on to the video.
Nagawa niyo ba ang red dem to? Head tilt chin lift maneuver? Guys?
Heimlich lang po, ma'am.
Heimlich.
Tapos napadaanan lang po yung head tilt chin lift po.
Okay, sige. Saan na ba tayo?
On to the video. The head tilt with chin lift maneuver and the jaw thrust maneuver are two of the main tools of basic airway management. First, we'll know why we have to perform jaw thrust or chin up maneuver. If the patient becomes unconscious when he is on his back, the muscles of his jaw and tongue get relaxed and the tongue falls against the posterior pharyngeal wall, blocking the airway. This leads to airway obstruction. Jaw thrust and head tilt chin lift maneuver helps in such a way that the tip of the chin points upwards, will move the tongue away from the pharynx and relieve the airway obstruction. Now let's see the perform head tilt and chin lift maneuver. The head tilt chin lift maneuver is a procedure used to prevent the tongue from obstructing the upper airways, which commonly occurs in an obtunded or unconscious patient. Tilt the patient's head back by pushing down on the forehead. Place the tips of your index and middle fingers under the chin and pull up on the mandible, not on the soft tissues. Because pressure to the soft tissues of the neck may obstruct the airway. So, be sure to pull up only on the bony parts of the mandible. This lifts the tongue away from the posterior pharynx and improves airway patency. Contraindications. Do not perform if a neck injury is suspected. Use jaw thrust instead of head tilt. Next, we'll see jaw thrust technique. The jaw thrust is a technique used on patients with a suspected spinal injury and is used on a supine patient. The jaw thrust maneuver more directly lifts the hyoid bone and tongue away from the posterior pharyngeal wall. Procedure steps. It is performed by placing the 3 fingers behind the angle of the mandible and pushing the jaw anteriorly. The rescuer may also place their thumbs gently over the cheeks to assist in pushing the jaw forwards. It is very important that when performing the jaw thrust, the rescuer places their fingers over the bony prominences of the mandible and not soft tissues, because applying sustained pressure to the soft tissues of the neck and or jaw could lead to trauma. Difference between head tilt chin lift and jaw thrust maneuver. A head tilt chin lift is used to open the airway of an unconscious patient. Jaw thrust is used to open the airway when a spinal injury is suspected. Okay, friends, that's all about today. I hope you all like this video. Subscribe to this channel for regular updates.
Okay. So, alam niyo na kung ano ang difference at saka paano yung technique. Okay? So, let's move on. Meron din tayong tinatawag na oropharyngeal airway. Okay? Oropharyngeal insertion. So, dapat nag-read din kayo nito. Meron tayong mga oropharyngeal device sa skills lab. Okay? So, it is also a semicircular tube na dapat i-insert kasi usually talaga kapag ang mga unconscious patient nakahiga, yung dila nila is nagbabara doon sa lalamunan. So to maintain the open airway, kailangan natin i-insert na oropharyngeal airway. Okay? And then to do this, may technique lang talaga kasi hindi dapat masugatan ang buccal cavity ni patient, lalo na yung palate area o kaya yung dila or lalamunan. Okay? So the tube is or the device is inserted into the posterior pharynx, okay? So that ma-open yun. Okay? And then after that, pwede nyo nang maintain yung oxygen by mask or by mask usually. Okay, tignan nyo dito.
A small simple plastic piece can save the life. Oral airway. In this video, we will demonstrate insertion for the oropharyngeal airway. Oropharyngeal airway will be used for patients who are unconscious, that they cannot, they don't have gag reflex, so they will not move it. You can use also the oropharyngeal airway for the intubated patient to prevent biting of the tube. There is different sizes. We need to select the proper size. There is no technique to insert oropharyngeal airway. Today we will demonstrate both of them. How to select the proper size for the oropharyngeal airway? By measuring from the patient's ear loop or angle of the jaw to the corner of the mouth. An oropharyngeal airway that is too small, it may push the tongue into the oropharynx and cause obstruction. And the large one, the too large one, it might obstruct the trachea. So we need to select the proper size. So the first technique based on the using of the tongue depressor, and you will insert the oropharyngeal airway as it will be placed in the patient mouth. There is actually another method which is like the most common we are using, which you will insert the oropharyngeal airway in the opposite placement. Then as the tip of the oropharyngeal airway reach the posterior wall of the pharynx, we will rotate the oropharyngeal 180 degrees while advancing it into the proper position. We need to make sure that the flange of the oropharyngeal airway is stable and positioned securely on the patient's lips. Hope you find the video useful. Thank you so much.
Okay, so madali lang naman i-insert yan, but kailangan maingat kasi mucous membrane ang kalaban natin yan, manipis. Ang oropharyngeal is medyo matigas yan. Okay, although some of it are silicone, medyo malambot, pero matigas pa rin. Sometimes kasi si patient, lalo na ang human being, kapag meron foreign na na pumapasok or things like, for example, sa bibig, pinipilit yan unconsciously if a fight against what is invading inside. So, pipilitin niya yung niya, yung ngipin niya, kakagatin or things like that. So, as much as possible, dapat may timing, may paano pag-insert, kahit na sabihin natin unconscious yung pasyente or semi-conscious. Okay? Sometimes we use the aid of the tongue depressor to insert. Okay? Yung tongue depressor, dinodoble yan. Dinodoble yung tongue depressor, binabalot ng gauze, and then put it in between the teeth bago hawakan kunti yung between the teeth and then touch the tongue so that hindi ma-obstruct yung tongue habang pumapasok si oropharyngeal airway. Ay, dapat nga pala magre-retdem yun ganyan. Meron ba kayong retdem na ganyan? Wala.
Wala po, ma'am.
Okay. So, himlik lang talaga ang retdem. Sige, tingnan natin. Ano pa ba? CPR nag-retdem kayo?
Yes po, ma'am.
Okay. So, endotracheal intubation. So, yung intubation, hindi natin trabaho yan. But that is one way of clearing or maintaining an open airway. Okay? And it is being done by an expert, particularly anesthesiologist or ang doctor or ER doctor na nag-train to insert endotracheal tube. Okay? So, this is to maintain airway lang talaga sa pasyente, particularly those patients who suffered from hypoxia. Okay? Then, this tube also, or this intubation is indicated to establish an airway for a patient who cannot adequately be ventilated with an oropharyngeal airway. Kasi di ba kanina sabi natin, para ma-open yung airway, pwede naman oropharyngeal. Bakit may ET tube pa? Sa kasi si ET tube, mas ano siya, mas malalim ang ano niya doon sa lalamunan. Okay? So, at saka mas nagbibigay siya ng proper, what do you call this? Proper ventilation sa alveoli. Okay? And what do you call this? This is much appropriate kapag ang pasyente ay nakakabit sa respiratory or sa ventilator or sa respiratory machine. Okay, keep watch. And here, ano ba tayo? Insertion ito, just to give you an idea kung paano ini-insert ang endotracheal tube. Pero hindi tayo gumagawa niyan, ha?
This is Dr. Cal Shipley with a review of endotracheal intubation. Let's start by taking a look at the anatomy of the throat. Musculature of the neck and throat is highlighted by the sternocleidomastoid muscles, both of which have two heads which attach to the sternum and clavicle on either side. Removal of the muscular layer reveals the trachea, the major airway connecting the nose and mouth to the lungs, and the cricoid cartilage, which provides an attachment point for multiple muscles and ligaments involved in the production of speech and opening and closing of the airway. Deep to the trachea lies the cervical spine. The cervical spine literally acts as the backbone of the throat and neck, providing major structural support, as well as providing a protected conduit for the spinal cord. On closer examination, we see the thyroid and cricoid cartilages, and housed within the thyroid cartilage, the vocal cords. Switching to a side view, we see the root of the tongue, the trachea again, ringed by its external cartilages, and behind the trachea, the esophagus. A cross-sectional view reveals the epiglottis, a flap of fibrocartilaginous tissue, which is attached anteriorly to the inner aspect of the thyroid cartilage. Lying posteriorly at the very back of the throat is the cervical spine. It is worth noting here that the area bordered superiorly by the epiglottis and inferiorly by the cricoid cartilage, and enclosing the vocal apparatus, is known as the larynx. The pharynx refers to that area of the airway lying directly above the vocal cords and the epiglottis. The purpose of the epiglottis is to allow for free movement of air in and out of the trachea during breathing, and to close over the airway during swallowing to force oral secretions and food down the esophagus and prevent their movement into the lungs. The inset on the left depicts a view looking down the throat as one might see it during endotracheal intubation. It is critically important to a safe and successful intubation that the operator be very familiar with the anatomical landmarks noted here. Again, we can observe the closure of the epiglottis during swallowing. Now that we've set up the relevant anatomy, let's turn our attention to endotracheal intubation. Endotracheal intubation is used whenever an assured protected airway is necessary in intubation, such as in emergency situations. The patient may be unconscious or have impaired spontaneous respirations, or during general anesthesia. A protected airway refers to the fact that the airway is protected from aspiration into the lungs of oral contents. And we'll see in just a few moments here how a properly inserted endotracheal tube protects against aspiration. In a cross-sectional view with the patient prone, the key anatomical landmarks are noted. A laryngoscope is used to accomplish the intubation. The laryngoscope has a removable metal blade. Laryngoscope blades come in a variety of sizes and shapes to accommodate variations in the throat and neck anatomy from patient to patient. Prior to insertion of the laryngoscope, the head of the patient is extended slightly on the cervical spine, pushing the chin upward, reducing the angle between the oropharynx and the upper airway. The blade of the laryngoscope is inserted to depress the tongue and open the epiglottis. It is critical that the blade chosen be of appropriate shape and size for a given patient, so that the tip of the blade can reach the hypoepiglottic ligament at the base of the epiglottis. When pressure is applied to the ligament as shown here, the epiglottis opens fully. The endotracheal tube is now inserted. Typically, a length of heavy but flexible wire is inserted through the endotracheal tube to conform to the shape of the airway and assist the operator in insertion. The endotracheal tube is inserted so that the inflatable cuff is pushed beyond the vocal cords. The laryngoscope is now withdrawn. The cuff on the laryngoscope lies beyond the vocal cords in the upper trachea, as noted here. When the cuff is inflated with air, it anchors the endotracheal tube within the trachea and also seals the trachea against the possibility of aspiration. As mentioned previously, this is what is meant by a protected airway. The patient is now ready for ventilation with either an ambu bag or a ventilator machine. Once ventilation has begun, the lungs are auscultated to ensure airflow and eliminate the possibility of esophageal intubation. Please see my animation on esophageal intubation in the resuscitation library for more information.
Okay, so ayan ang pag-insert ng endotracheal tube. Okay, docs? At saka hindi tayo ang gumagawa niyan ha, mga doktor. Okay, now meron din tayong ibang klaseng ET tube na pwedeng i-insert, pero this kind of ET tube, pwede ito sa mga bahay. Pwede ito dalhin pwedeng iuwi si patient sa bahay na nakaganito. Okay? O kaya pwede kung for example, discharge na siya, tapos na siya sa bahay lang, ayan, pwede ito ang gagamitin kasi medyo mas safe at design siya talaga pang bahay. Okay? Picture lang yan, wala nang iba. Okay. So maintaining ventilation. Ensure ventilation is adequate by checking the equal bilateral lung sounds. Kaya nga, nung second year kayo, tinuro na sa inyo kung paano ang pag-auscultate ng lung sounds. Okay? It should always be bilaterally. Okay? So kung ano yung naririnig mo sa isa, lipat mo doon sa isa. Dapat partner lagi. Okay? And then, teka lang. Yung pag-auscultate, di ba kunyari ilagay mo sa right lung, okay, sa may sa may apex ng lung. Saan ang apex ng lungs? Saan banda sa likod? Anyone? Andyan pa ba kayo?
Yes po, ma'am.
Okay, Jerome, saan banda ang apex ng heart? Ng lungs.
Wait lang, ma'am. Dun sa lectures po namin, hindi ko sure, ma'am, pero yung sa unang rib po ba yun, ma'am?
Okay, so malapit sa shoulder, diba? So yung doon banda ang apex, yung malapit sa shoulder, yung unang rib, okay na yan sa'yo, okay na yan. So ilagay mo dyan ang stethoscope mo sa likod, pagkatapos lipat ka, kunyari sa right, tapos lipat ka sa left. So at least narinig mo ang left and right, equally distributed ba ang air? Tapos, hindi ka muna bababa papunta sa right ulit kasi ibababa mo yung stethoscope mo sa left kung saan ang huli mo nilagay. Ibaba mo lang konti. Okay? After that, pakinggan mo ulit after inhalation and then ilipat mo na ngayon sa right. Hindi yung right, left, hindi. Kundi right, left lower, and then right lower, and then right much lower, and then left much lower. Yung ganon. Hindi yung salitan, alternate na lipat-lipat kaagad. Okay? So, this way, you will see if uniform ba ang air entry o hindi. Okay? Kaya nga, kapag na-check mo yan, usually, inaano pa natin yan, lalo na mga pasyente with respiratory problems. We describe that properly in our nursing notes. Okay? Breathing spontaneously, on auscultation, air entry is equal on both lung fields. Ganon lagi ang nilalagay natin, particularly kapag meron nga talagang problema sa respiration si patient. Okay? So, this way, na masasabi mo na, oh, inassess niya. Kumbaga, kung for example, may inassess niya pala kanina, equal air entry daw. Sometimes mailagay mo pa yung with minimal crackles, yung mga ganyan, or kung ano yung naririnig mo sa sound, sa auscultation. Okay. Satisfactory management of ventilation may prevent hypoxia and hypercapnia. Weakly assess or of absent diminished breath sounds, open chest sounds, and difficulty delivering artificial breath for the patient. Kailangan check agad yan. Bakit? Naka-ventilator naman siya. Bakit kaya? Saka nag-a-alarm ng ventilator. Ang hindi pala alam, yung mga tubings, puno na ng tubig. So wala nang dumadaan, may obstruction na. Kaya nahihirapan si patient. Tanggalin yung tubings, tanggalin yung tubig sa tubings. Kasi yun nang o-obstruct. Okay? Sino ba dito nakapag-duty na sa ICU? Na may ventilator ang pasyente? Meron na ba sa inyo? Wala pa ni isa? Okay, walang problema kasi sa second SEM, meron na kayong intensive nurse practicum. Okay, sa intensive nurse practicum nyo, halos lahat ng araw, 3 days talaga kayo yan sa hospital. Intensive na. So, pwede kayo ma-assign kahit saan-saan. So, by the time siguro ma-experience nyo, okay, the whole semester may INP kayo. At mabigatan yan, mabigatan na duty kasi araw-araw, 3 araw. And then, ang 4th day siguro sa kayo, sa COPAR din. Okay? So, ayan, monitor pulse oximetry, capnography, and arterial blood gases if the patient requires airway or ventilatory assistance. But again, in our prelim, nakita na natin or na-discuss na natin about yung mga arterial blood, mga capnography and things like that, di ba? Ito yung mga oxygen saturation na tinitignan, na ini-interpret ng monitor. Okay? Kaya nga, meron tayong mga tawag yun. Ano ba yung mga ito nawala sa utak ko? Yung mga monitor na cardiac monitor, na lahat na, pinakita ko sa inyo last time, di ba, yung mga monitor na nandun na kompleto, isang lagay mo lang, kuha mo na talaga lahat ng mga parameters niya in 1 minute. Okay? Particularly sa mga pasyente with ventilator, with cardiac catheter, and things like that. Kasi nakikita lahat yan through the transducer. Si transducer ang nag-i-interpret niyan para maging visible sa machine na ito ang interpretation. Okay? So, asan na tayo? Tension pneumothorax can mimic hypovolemia. So, ventilatory assessment precedes assessment of hemorrhage. Okay? So, kailangan talaga. Malalaman niyo naman, ang pinaka-distinct lang talaga kapag may internal hemorrhage is to check the blood pressure. Kapag nagda-drop yan at ang taas ng pulse rate, suspect na yan. Pwede na ipa-x-ray si patient para malaman kung saan banda ang bleeding or CT scan. Okay? Then, a pneumothorax or sucking chest wound is managed with a chest tube, immediate relief of increasing positive intrathoracic pressure, and maintenance of adequate ventilation should occur immediately. Always remember, guys, breathing operates at negative pressure. Okay? Kapag may open wound, may open na ano, ito na yung tinatawag natin na alter ang negative pressure sa loob, naging positive pressure. Ayan, nagkakaroon ng tension pneumothorax. Okay, remember guys, sinabi ko sa inyo yung sa exam natin, hindi pwede ang hemopneumothorax kasi iyon ay talagang may open at na-penetrate ang dugo at ang hangin sa loob. Okay, may sugat. So, hindi siya pwede ang maging answer niya. Okay? Once na open, kaya nga kapag, for example, nalagyan ng chest tube ang pasyente, you really have to make sure that the tubings are intact and sealed. Walang mga leak. Kasi this will create positive pressure inside. So, hindi maka-inflate ng maayos ang lungs. Okay? So, ayan. So, kailangan maintain. Kapag na-dislodge, immediately i-clamp mo yun. Okay? Dapat huwag mo na huminga si patient and then clamp ka agad ang tubing. But hindi naman talaga madidislodge yun kasi natahi. Natahi yan sa balat ni patient. Yung pinaka-tubing na connection sa what do you call this, sa water seal drainage. Ang problema lang dyan, yung pinaka-water seal drainage, baka ma-leak o kaya magkaroon ng butas-butas, whatever, magkaroon ng positive pressure. You discuss about water seal drainage sa RLE nyo? Alam ko na meron kayong project to devise or improvise a water seal drainage. Isa yan sa clinical focus na kasulat. Ginawa niyo ba yan? Uy, wala ba kayong boses? Nandyan pa ba kayo?
Nag-discuss lang po sa MS2 po namin.
Hindi
MS,
po nagawa, ma'am.
MS2?
Na-discuss lang po. MS1 po.
Nadaanan po.
Hindi. Yung RLE, may RLE tayo na to discuss about water seal drainage. And then, isa doon is kailangan gumawa kayo ng water seal drainage project. Kumbaga project nyo yun for midterm. Wala kayong ginawa? Hindi kayo pinagawa?
Hindi po, ma'am.
Anong pinaka-exam nyo doon? Midterm. Anong RETDEM? Kasi lahat to MS1 eh. Sa MS1 nyo to mga RETDEM na yan. Yung pulse oximetry, prelim yun. Okay? Yung pag-insert ng pag-apply ng oxygen, yung mga ganyan. Prelim yun. Yung chest physiotherapy, yung positioning, yung postural drainage. Ano yan? RLE nyo yan. RETDEM yan. Okay, so saan na tayo? Anyari, ang dami niyong walang ginawa. 6 weeks tayo, walang nagawa ang project, wala kayong nagawang ganyang RETDEM. Balik tayo, hemorrhage. Okay, so stop bleeding or stopping bleeding is very important. Okay? And it is one of the, primary action na ginagawa natin when it comes to emergency or disaster situation para ma-survive si patient. Okay? So, hemorrhage that result in the reduction of circulatory blood volume is a primary cause of shock. So, kailangan alamin saan ang origin ng bleeding na to at kailangan i-stop. Open wound, okay lang kasi kailangan i-seal mo lang yun. Okay? I-stop mo lang, lagyan mo lang ng pressure para hindi na siya mag-bleed. Pero what if nasa loob ang bleeding na hindi natin alam, di ba? Okay, next. Minor bleeding, which is usually venous, generally stops spontaneously under the patient, unless the patient has a bleeding disorder or has been taking anticoagulants. Now, yung mga minor bleeding, di ba, usually yung nag-cut ka, yung, kunyari, nahiwa yung daliri mo. Okay? magbe-bleed ka. Kahit na sabihin mong malaking diwa, yan. Magbe-bleed ka din. Okay? Magbe-bleed ka din ng ganyan. Pero apply mo lang pressure. So the moment that you apply pressure, yung coagulation cascade din natin ay nagwo-work out na. Ayan na, dumadating na si platelet, si fibrin and everything to form a clot. Okay? Wait lang ha. Sorry guys, may pumasok. Nandito kasi ako sa opisina sa EAC North. Okay, so hemorrhage that result in the reduction kay ang cardiac output ay magre-result sa shock. Okay? Now, kagaya na sinabi ko kanina, pag may cut ang daliri, okay? Kunyari, sugatan ka sa kutsilyo, ilagyan mo lang ng pressure yan, di ba? Medyo malalim, kumbaga. Lagyan mo lang ng pressure yan, after few minutes, mag-stop na ang bleeding. Okay? Now, mag-stop ng bleeding kasi nagtatrabaho na dyan si coagulation cascade. Pero kung for example, yung pasyente na yan o ang tao na yan ay meron mga medications that can prolong the bleeding, so magpapalong bago mag-stop ang bleeding. Okay? Particularly yung mga alcoholics, particularly yung mga taking anticoagulants and things like that, matagal mag-stop ang bleeding. Ang anticoagulant baka hindi pa mag-stop, delikado. Okay? So, kailangan talaga maintain ang pressure. So, there are two types of bleeding. We have the internal and the external. Okay. So, sa internal bleeding, yun yung delikado dahil hindi natin alam kung asan at papano. So, ano-ano bang mga conditions na pwede natin masabi na posibleng magkaroon ng internal bleeding? One is blunt trauma. Okay? So, we will discuss that dito sa emergency nursing ang blunt trauma, pero not now. Another thing is ulcer. Okay? Ulcer can also cause bleeding. So, kapag bleeding, kapag yung maramihan na, ito yung tinatawag natin na hemorrhage. Okay? Ay, wait lang.
Yung box yun, ma'am, para makita.
Okay, so balik na tayo. Okay, so hemorrhage, ang sasabi natin na kailangan talaga natin magkaroon or kailangan talaga ng fluid resuscitation immediately. Okay? So fluid resuscitation or fluid replacement to maintain the circulation, to maintain yung cardiac output para magkaroon ng perfusion ang mga cells or tissues. Okay? Now, paano tayo gumagawa ng fluid resuscitation? Make sure that when you give the IV to the patient, you use gauge 18 needle. Okay, yung IV needle, kailangan gauge 18 to be inserted in the large vein. Okay, kailangan sa large vein yan. And another thing, kailangan dalawa. Magkabilaan yan. So kung for example, wala talagang makuha, pwede sa paa. Pero again, sa paa is the last resort. Hindi pwede sa paa talaga. Okay? Now, there are some instances na hindi kaya talaga sa braso at sa paa. Saan nilalagay? Sa jugular veins. Okay? So, if the patient is in shock, collapse lahat yan, pati mga blood vessels hindi makaano, wala nang hindi na inflated. So put the patient in a Trendelenburg position so that you will be able to visualize the jugular vein, and that's where you can insert the needle or the catheter. Okay? Para kaagad meron ng fluid si patient. Pero kung tutuusin, kailangan talaga as much as possible, don't put into the jugular veins kasi you remember na diretso ang tubig na yan, fluid na yan sa right atrium. Okay? Kailangan kasi aseptic technique pa dyan, at chuchu, ang dami pang mga precaution na dapat. Pero kung sa peripheral lang, sa mga braso at paa, pwede. Okay? But as much as possible, kailangan malaki ang needle, usually gauge 18. Okay? Replacement of fluid are administered as prescribed depending on the estimate or the type of volume of fluid loss. Okay? So usually talaga lactated ringers or normal saline or colloids. What are example of colloids? Ito yung mga albumin and things like that, and other blood components. Pwede direct blood transfusion na din si patient kapag nakita nga nila ay sobrang laki na ng nawalang dugo sa kanya. Okay? Now, usually talaga, pack Ala, kanina pa ako nagsasalita. Yung pala, kanina pa ako nagsasalita, nakamute pala. Sorry guys. Okay, balik na lang ako sa topic. Okay, so usually talaga kapag hemorrhage talaga, sabi natin is the patient really needs fluid resuscitation. Okay? Ito yung to replace all the lost fluid in the fluid volume sa body ng pasyente. Remember, 75% fluid and the other is blood. Pero kapag bleeding na yan, pati kung ano-anong mga components na wala, patay talaga. Yung blood na lumabas ay delikado. Baka wala na talagang perfusion mangyari. But to maintain the fluid volume para at least kahit papano mayroon dumating na oxygen sa brain, fluid resuscitation tayo. And then after that, pwede kasunod na si blood transfusion, blood replacement. Okay, ang kagaya ng sinabi ko, meron tayong, what do you call this, different kinds of blood components. Ano ba talaga ang nawala ni patient? Ano ang kailangan ni patient? But blood transfusion should be administered after being cross-matched and typed. Hindi pwede basta na lang kung may dugo dyan, salpak. Hindi. Kailangan blood typing pa yan, and then blood cross-matching. Did you discuss this in your RLE? Yung mga blood transfusion, chuchu?
Yes po, ma'am.
Okay, very good. Okay? So alam nyo na kung sino ang universal donor and universal recipient. Alam nyo na yon. Hindi pa.
Alam na.
Okay, very good. So alam nyo na marami tayong mga blood components. Now, when it comes to fluid resuscitation, we can either give whole blood or packed RBC. Okay, so anong kaibahan ng dalawa? Anyone? Meron ba? Uy, anong kaibahan ng dalawa? Akala ko ba diniscuss nyo na yan? Uy, bilisan nyo na kasi mag-break muna tayo. Nagugutom na ako. Yes, Jerome?
Try lang po ah.
Mm.
Yung ano po, whole blood ma'am is ano talaga siya, kung as is na po siya kung paano nakikita sa katawan talaga ng tao. Tapos yung pack RBC po ma'am, mas compress po yung RBC niya ma'am, so mas mataas yung hematocrit levels po.
Okay, very good. Ayan, simple lang kasi nandun ang exponent pack RBC. RBC lang lahat yun. Okay? So whole blood, kasi kung for example, wala pang ibang choice, kailangan na talaga ni patient dahil hemorrhage, ang dami na so pwede mo siya bigyan ng whole blood. Okay? But again, kailangan talaga ng tawag dito, blood typing and cross-matching. Okay? So, madali lang naman ang cross-matching. Pag ganyan, kaagad pwede na isalpak yung dugo. Now, talking about blood transfusion, so away na yan dito kasi sa ano na yan, sa RLE na yan eh. Okay, now let's move on to talk about another interventions. Patient's clothing is cut away in an attempt to identify the area of hemorrhage. Kailangan talaga alamin kung nasaan ang origin ng hemorrhage. Okay? Kung physical ba yan or internal. And then direct firm pressure is applied. Most bleeding can be stopped at least controlled by application of direct pressure. At check arterial bleeding results in death. Now remember guys, iba ang arterial at venous bleeding. Ang venous bleeding, tuloy-tuloy lang, ganon, lumalabas lang. Parang swabe lang siya, parang relax lang ang paglabas ng dugo. But if that is, what do you call this? If that is an arterial bleeding, parang ano yan, parang hose. Kita nyo yung hose na nalagyan mo ng pressure, ay, ang bilis talaga. Diba? Sometimes pwede pa yan mag-fountain. Okay? Depende talaga. Mabilis talaga ang labas niyan. So, napakadelikado ang arterial bleeding kaysa sa venous bleeding. Okay? Bukod sa si venous is to return to the blood, ito galing pa to sa galing to return to the heart, ang arterial is papunta pa lang sa circulation. So mas delikado 'yun. Hindi na talaga mapupunta sa mga periphery ang supply dahil lumabas na, 'di ba? Nag-bleeding na siya palabas. Okay? So, it should be checked. Kung hindi talaga patay tayo, walang oxygenated blood ang dadating sa mga dapat niyang dadatingan. Okay? So, a firm pressure dressing is applied and injured part is elevated to stop venous or capillary bleeding. So, venous and capillary yan. If the injured area is an extremity, it should be immobilized, a little bit elevated, okay? Para makontrol yung dugo. Never ever use tourniquet to stop the bleeding. Kasi aside from papatayin mo yung mga cells doon dahil sa tourniquet, pati nerve isisira mo pa. So tourniquet should be used as last resort. Okay? And take note naman sa mga mga pulse checkpoint natin. Okay? When we talk about hemorrhage, we have to make sure na lahat ito ay chine-check para malaman natin saan ang malakas pulsation or mahinang pulsation. Kapag mahinang pulsation, ibig sabihin mahina din ang daloy ng dugo dyan. Okay? So, ayan. So kapag may hemorrhage, kailangan talaga nakahiga na lang flat para at least kahit sa brain may dadating, di ba? Now, if there are no external signs of bleeding, but, okay, remember, nandito na tayo sa internal. Kung wala kang makitang signs ng bleeding sa pasyente mo na dumating, okay, alam mo na aksidente siya. Ito yung mga blunt trauma na sinasabi. Wala. So, pero meron silang tachycardia, meron silang blood pressure na that is dropping. Okay? And then meron silang parang, meron ang itsura nila yung parang may impending doom. Okay? So, suspect na kayo na meron siyang internal bleeding. Lalo na kapag yung skin niya is parang basa-basa, parang pawis na ewan, tapos namumutla. Okay? And
Cold,
then, hello, yeah?
yung cold clammy po.
Yes, cold clammy. Okay? And then very poor capillary refill. So expect nyo na yan na mayroon siyang internal bleeding. Okay? Again, you can administer blood in a rapid rate. Di ba ang blood transfusion natin dapat within 4 hours it should be. Now, this is a normal blood transfusion. Pero kapag bleeding na yan, kapag hemorrhage na yan, fast drip na yan siya. Okay? Fast drip na yung blood. Meron nga dalawang units pa or dalawang bag of blood pa na binibigay kay pasyente. Okay? Kasi nga, kailangan talaga i-resuscitate ang condition niya. Arterial blood gas specimen are obtained to evaluate the pulmonary function and tissue perfusion. Kasi di ba galing siya sa hemorrhage, nawala na lahat. Nagbigay na tayo ng fluid resuscitation at blood transfusion. So ngayon, check na natin. Perfuse na ba maayos? Tinanggap ba ni mga cells na maayos yung dugo na binigay natin? Yung mga ganyan. Ginamit ba nila yun? O di ba? Kasi kung hindi, ibig sabihin, ang next mo is anaphylaxis na. So, delikado din. Now, in some cases, itong may mga doktor, nagbibigay na sila ng preventive measures like magpa-inject na ng Benadryl para bago i-start ang blood transfusion and things like that. Pero in other cases, kapag compatible naman ang blood sa cross-matching, so, hindi na, diretso na lang. Okay? Then, asan na ako? Okay, dito na tayo sa arterial blood gas. Dito din natin masasabi kung ano ba ang condition ni patient, o kailangan pa ba niya ng fluid resuscitation or oxygen therapy, ilang percent ang kailangan, yung mga ganon. Okay? Na sa ABG pa lang, ang dami na natin interpretation pwedeng ikuha. Lalo na kapag nasa patient, if the patient is having the verge of acidosis or alkalosis, di ba? So mga bagay na yan. Then, the patient is maintained in a supine position to monitor closely until yung condition niya is hemodynamically stable. Kasi improve na yung mga parameters niya. Okay? Until na masabi mo, oy, okay na to. So, pwede na to, diretso na to sa operating room para itahi na yung, butasan na yung butasan. Ihiwa na yung katawan, tapos itahi na yung, kung ano yung cause ng bleeding sa loob. And then after that, pwede na siya sa ICU for close monitoring. Okay? Now, if, for example, usually talaga si accident, sa mga trauma na yan, meron din talagang hypovolemic shock, hypovolemia. But hypovolemia is not only for mga accidents, okay? Pwede din siya sa mga sobrang dehydrated na iniwan lang sa disyerto na walang tubig and things like that. Pwede din magka-over-dehydrated siya, hypovolemia din yun, okay? So, inadequate organ and tissue perfusion follows after hypovolemia. Okay? So, because of that, again, anong mangyari? Walang proper cellular metabolism ang mangyayari. So, should always be immediately intervene. Kailangan ma-intervene mo na kaagad. Okay? So, ano ang gagawin? Alamin mo muna kung ano ang cause ng shock. Okay? Hypovolemia ba talaga yan? Or cardiogenic? or because ba sa neuro kaya nagkaroon ng hypo, or anaphylaxis kaya nagkaroon ng hypovolemia and things like that. So it should be determined para malaman natin kung ano ang paanong action ang gagawin natin. Like for example, sa anaphylactic shock, nagkaroon ng hypovolemia si patient. O bakit may hypovolemia to? Ano ba nangyari? O nalaman mo na nagkaroon ng hypersensitivity, severe allergic reaction dito sa kinain niyang hipon or kinain niyang, ano ba tawag nun? Yung kung saan allergic talaga siya. Okay? So, nagkaroon ng anaphylactic shock. So, pwede siya bigyan ng antihistamine. Okay? Para at least ma-decrease ang production of histamine para walang mangyari anaphylaxis. And then, treat na after. After na-treat mo yun, ayan, bigyan mo na kaagad siya ng immediate secondary treatment. Fluid resuscitation. Okay? Or pwede din, alam mo na ang kaagad, syempre pagdating yan, wala pang kaalam-alam sa history, alam mo na talagang si patient is sobrang nag-hypovolemic na, fluid resuscitation. And then after that, bigyan mo na ngayon after na-assess mo, bigyan mo na ngayon kung ano ang pinaka-treatment of choice para sa pasyente who is having anaphylaxis, cardiogenic, or neurogenic shock. Okay? Kasi hindi mangyayari ang hypovolemia kung wala sila. So, i-treat mo muna yung hypovolemia and then treat mo yung kung ano ang nag-cause nila. Nagko-cause ng hypovolemia. Okay? Next. Wounds. So, ito ay ano lang to, hindi naman sa masasabi mo sugat lang na kinamot mo, nasugatan tayo, iyan na. Pero isa din to sa mga klaseng wound na sinasabi that cause from trauma. Okay? So, ibig sabihin, ito yung mga like for example na aksidente, magkaroon ng malaking parte ng katawan ng nasugatan or na nagbubog. Pero sa loob yon bleeding na yon. Sa loob yon crushing injury na yon. Okay? So ano ang goal natin dyan kapag may wound? Restore the physical integrity and function of the injured tissue. Teka, sabi ko alas 10, break muna tayo, nagugutom ako, kakape lang ako. Okay? Balik tayo ng 10:30. Okay, Dukes?
Okay po,
Okay po,
ma'am.
ma'am.
Bye. Tapos na ba kayo? Tapos balik na kayo?
Yes po, ma'am.
Okay. So, balik na tayo. Now, we are talking about wounds and ang sabi natin, hindi lang ito basta wound, hindi lang ito basta cut. Okay? This is somewhat like a trauma wound. Okay? Sometimes masyadong malaki, sometimes masyadong maliit, sometimes makita mo bruises lang pero ang bleeding nasa loob. Okay. Now, what is the this thing about wound? Ina-assess kasi natin yan pagdating sa pagdating sa ER. Tapos pwede natin siya i-classify. Okay? Aside from sinasabi natin na trauma wound, pwede din natin further classify them as medico-legal. Okay? Trauma siya pero because of medico-legal. Ano yung medico-legal? Ito naman yung mga nagpapatayan, nagsasaksakan, yung mga ganung bagay. Okay? So, minsan nag-aaway, mga gang-gang, ganon. So, pag ganon, hindi natin basta-basta i-manipulate mo na ang wound. Okay? Aside from stopping the bleeding, kailangan meron pa tayong mga bagay na ginagawa kasi kailangan i-preserve yung kung ano ang meron natin nakita dyan. Okay? So, kailangan i-check natin. Here, we have proper documentation for future forensic evidences. Ito na yung the characteristic of the wound. And pag nag-describe ko, pag nag-charting ka, kailangan precise description ang gagamitin mo and precise terminology. Okay? Pati yung pinaka-size ng wound, yung lalim ng wound, yung itsura ng wound, dinedescribe yan. Kailangan kung meron, ngayon kasi uso na sa atin ng cellphone, nasa bulsa na lang ng mga nurses. So pwede natin kuhaan ng picture. But again, based on privacy, you really have to ask permission. Ask mo permission ng pasyente, papayag ba siya, nakuhaan siya ng, what do you call this? Picture, kuhaan ng picture yung wound niya, lalo na kapag sa may mukha. Pero kapag sa may mga baba, sa extremities and things like that, walang problema, maliban lang sa genital area din, okay? Because photographs are helpful because they provide an accurate visual depiction of the wound. Okay? So, hindi na i-imagine ng mga medico-legal kung ano ba itsura ng wound dahil may picture na kaagad. Okay? So, yun lang ang pinaka-difference kapag meron wound na nag-present sa iyo sa ER. Determining when and how the wound occurred is important. Kasi kailangan natin yan based on ano ba ang dapat treatment ibigay natin kay patient. Okay? Using aseptic technique, the clinician inspect the wound to determine the extent of damage of underlying structures or the presence of any foreign body that has incurred doon sa wound. Okay? And then i-check natin ang distal function ng wound. Okay? Diba, kunyari, nasugatan ka sa may legs, i-check mo yung lower part. Okay? Check the sensory motor, vascular function to determine kung meron bang mga impediment nangyari o kaya na-damage. Okay? Lalo na yung nerves. Okay, docs. Then, ito yung mga description na kailangan natin gamitin when it comes to wound. Meron tayong the laceration, avulsion. Makikita nyo din ang mga picture nito kapag we are going to discuss later. Hindi this week. Pero within the topic ng finals, meron tayo nito. Okay, abrasion, ecchymosis. Okay, alam niyo naman ang hematoma, yung stab wound, cut, and pattern. Okay? Mga pattern wound, nagkakaroon ng pattern wound dahil na nalata sa gulong and things like that. Okay? So ito yung tungkol sa wound. So napaka-importante kapag na-classify niyo yan, medical legal, proper documentations ang kailangan. Okay? So next, let's talk about the cardiopulmonary resuscitation. Ang alam ko, gumawa kayo ng RETDEM nito, di ba? Meron kayong RETDEM? Uy, andyan ba kayo?
Yes po, ma'am.
Yes, po.
CPR.
Lahat ng klase, lahat kayo meron?
Ma'am, yung iba daw po, hindi pa po nakakapag-RETDEM ng kahit na anong skills po.
O talaga, pakilista nga ang pangalan. Tsaka anong group? Sila Daryl ba yan? Daryl, sa inyo ba? Ni isa wala?
Ma'am, sa amin naman po kasi hindi po siya na-redeem, pero pag halimbawa po may patient na tuturo naman po sa amin, pero hindi lang po talaga redeem.
Hindi, yung within your 6 weeks, anong ginawa? No, kasi dapat meron
Puro OR po kasi kami, ma'am, eh. Tapos na-o-observe din po namin yung iba, katulad po yung ano sa endotracheal tube po pag
Okay.
yung sa OR po kasi madalas din sa amin.
Oo. Pero meron tayong upcoming activity na ginagawa ng council. Lahat ng 4th year is required to attend. Hindi pa ako masyadong well, tawag nito, informed about the activity, but all 4th year should undergo the workshop. It's somewhat like workshop wherein mag-ano kayo ng cardiopulmonary resuscitation. Kasama din kami, pati kami kasama kami. Yes, Alexandra. Oo. Eh di, excuse kayo sa duty kasi kasama kayo dito kasi ang sabi ni din lahat ng 4th year. Pero sino nagsabi na puro lecture lang? Lecture subject? Ano-anong day yun? 28, 29, 30? Sige, kausapin ko si Shane. Kasi ang pagkaalam ko, lahat kayo dapat mag-attend. Kasi gagamitin nyo yan. Kasi magkakaroon kayo ng certificate niyan. And then, that is a good thing also kasi kung mag-apply kayo ng trabaho, meron na kayong certificate hawak na nag-attend kayo ng workshop and things like that. Pero ang pagkaalam ko, lahat ng 4th year pa-attend dahil by the second sem, pag second sem nyo, i-cascade nyo yan sa COPAR. Kayo ang magtuturo sa mga community about CPR. Yun ang pagkaalam ko. Pero clarify ko mamaya, bakit puro lecture lang? Sige, clarify ko mamaya, ha? Okay, Dukes. So siguro, hindi na natin i-discuss yan. Diyos ko day. Okay, now, but hindi na natin i-discuss kung paano ginagawa ang arrest, pero at least alam natin kung ano-ano ba, kung bakit ina-arrest yung pasyente. Okay, so there are different types of cardiac arrest. We have asthma cardiac arrest. Because of asthma, nagkaroon siya ng cardiac arrest. Tapos, cardiac arrest during PCI. Ano yung PCI? Percutaneous insertion, yung habang ginagawa ng procedure sa puso. Okay? May mga procedure na ginagawa sa puso sa cardiac laboratory. Ayun, nagkaroon siya ng cardiac arrest. Okay? Cardiac arrest because of cardiac tamponade. Okay? Alam niyo ba kung ano yung cardiac tamponade? Yan kasing puso natin, meron pa yan pinaka-lining. Okay? Yung pinaka-lining, ito yung tinatawag na pericardial sac. Okay? So yung pericardial sac, meron naman yan kunting fluid or liquid dyan para lang to lubricate para pag contract ng puso, yung yung freely siya mag-contract. Now, in some instances, itong pericardial sac napupuno ng tubig of no reason. Sometimes may reason because of trauma, because of nabangga or whatever, kaya nagkaroon ng tamponade. You will learn about that later also when we talk about mga accident. So yung puso, yung pericardial sac napupuno ng tubig. So it gives no room for the myocardium to contract. Kung mag-contract man ang myocardium, kunti lang, maliit lang. Okay? Dahil sumisikip ang environment niya, wala siyang room para mag-expand ang contraction. Okay? So unti. So ano ang outcome nito? Kunting cardiac output lang ang pwede niya ilabas. And this can lead to cardiac arrest kapag hindi talaga pwedeng mag-contract si heart. Lalo na kapag may cardiac tamponade na siya tapos nag-stress pa siya, ayun, pwede magkaroon ng cardiac arrest. Droning cardiac arrest, so alam niyo na kung bakit. Napuno kasi ng tubig yung lungs. Sana ngayon mangyayari? Paano na ngayon mapunta yung oxygenated blood papunta sa heart? Wala na, di ba? So, nagkaroon ng cardiac arrest. Electrocution cardiac arrest. Ayun, nakuryente kasi. Okay? So, depende kung ilang watts yan ang kinoryente mo. Hindi naman yung kuryente lang ganyan. But the good thing this time, yung mga socket natin sa bahay, and most of the socket, because of a many incident of electrocution, na kunting ganyan lang, kuryente na, iba na ngayon. Lalo na yung mga high voltage kind of, tawag nito, kuryente. Instead na didikit ka, tumatalsik ka. Okay, yun, alam mo, hindi ko pa na-try ha, pero based on yung sa mga seminars about this, mga safety, so dun ko nalaman na yung mga socket natin, lalo na yung mga high voltage, hindi na yung sabihin na didikit ka doon kapag nakuryente ka, tatalsik ka na. And that is a good thing kasi pwede may 50-50 pa kung ma-survive ka o hindi sa kuryente. Okay? Electrolyte imbalance cardiac arrest, particularly potassium. Bakit kaya potassium? Anyone? Sino pwede mag-connect? Sige, Jancel.
Yung pag-pump, involved po kasi yung potassium sa pag-pump ng heart po natin, ma'am. Sa
Okay, very good. So kung mataas ang potassium, anong mangyari?
mas mabilis po yung pump po, ma'am.
Magkaroon ng cardiac arrhythmias.
Yes, ma'am.
Okay? So the arrhythmia itself hindi mo masabi kung anong arrhythmia meron ka, pero ang taas talaga ng potassium level mo. Minsan naalala ko, isang pasyente ko, renal failure siya. Tapos at 6 a.m. kinuhanan ng dugo. Usually routine yan sa amin pagkukuha ng dugo, pag ready for dialysis sila and things like that. So tumawag yung laboratory. Kausapin yung nurse ni patient. Ang time ko doon, ang ginagawa ko noon is hinahanda ko yung pasyente kasi nga ready na siya for dialysis. So, sabi niya sa akin, buhay pa ba yung pasyente niyo dyan? Kasi yung potassium niya is 6. Di ba anong normal ng potassium?
3.5 to 5.5.
Okay. Now, some textbook says 5.5 ang range sa taas. Pero in some textbooks hanggang 5 lang. Okay? Pero again, kung for example ganyan, it depends on the machine and the reagent that they are using to check for the potassium sa serum ng pasyente. Now, ang gagawin natin is to observe the patient. Check mo yung pasyente. So yung pasyente ko 6, tapos sabi niya sa akin, ano ba, buhay pa ba yan? Hindi ba na-arrest yan? Sabi ko, wala naman. Ready na siya for dialysis. Ganun. Sabi niya, okay. Kasi ang taas ng potassium, 6, ganun. So, obviously, kung titignan mo yan, baka meron na siyang mga arrhythmias na hindi lang napansin kasi wala siyang monitor eh. Kasi renal failure siya, wala naman siyang cardiac problem. So usually talaga, dapat lang talaga i-expedite na ang pag-dialyze sa kanya para ma-wash out na yung mga extra potassium. So far naman, swerte ni patient kasi i-start na yung dialysis sa kanya. Okay, kasi kung pinabayaan pa yun matagal, ay ayan na, apektado na si heart. Okay, pulmonary embolism. The same way, kapag may embolism tayo, matatrap ang mga gas exchange doon, walang mangyayaring gas exchange at depende kung saan banda ang embolism na yan, pwede ma-impede ang blood flow pabalik sa heart. Okay? So pwede siya magkaroon ng what do you call this? Cardiac arrest. At the same time, mismo yung pinaka-embolism, yung pinaka-embolus na naglag, si patient magkakaroon ng respiratory distress. Okay, so the distress also will lead to inflammatory response. So alam niyo naman kung ano yung inflammatory response. So pati mga alveoli sarado, hindi makapag-exchange ng oxygen. Okay? So leading to cardiac arrest. And of course, trauma cardiac arrest na hindi na natin pwedeng dahil sa mismo pa lang sa salita, alam na natin kung ano yan. Okay? So, meron akong video dito, hindi ko na maalala kung ano ito, pero check natin.
We all know that CPR saves lives, but to
CPR.
perform effective CPR, it requires a highly organized team with clear roles and responsibilities. As we watch this video filmed at the Ochsner Simulation Center, pay attention to how the roles shift as the patient's condition transitions from a rapid response into a code blue.
Okay. Ito yung paano yung coordination, collaboration, teamwork sa ER. Ito yung sa ER. So, tignan nyo dito kung ano ang mga roles nila. Di ba sabi ko sa inyo, kahit hindi magsasalita, ginagawa na nila. So, ayan. Yung traffic, meron nagta-traffic, meron meron nagdo-document, meron nagtutulong sa doktor, yung mga ganyan. Okay, so tignan niyo ito. Ito usually nangyayari sa ER.
Clinical deterioration can happen at any time. Early intervention starts with the bedside nurse who assesses the patient and calls for support from the charge nurse if she feels something is just not right.
Hi, Mr. Jones. This is your nurse, Kiara. I came in to check your vital signs. How are you feeling today? I'm going to go ahead and get your blood pressure. Your blood pressure is a little low. I'm going to go ahead and call my charge nurse for some support. Hi, right now. This is Kiara. I'm in room 926 with Mr. Jones. He doesn't.
The bedside nurse provides a quick report to convey any urgency or signs of clinical deterioration. The charge nurse immediately responds to support the bedside nurse and provide a secondary assessment of the situation.
Hey, what's going on? Hey, this is Mr. Jones. He came in last night. This morning he was feeling fine. I just checked his blood pressure. His systolic was in the 80s. He said he feels like he's about to die, and he said he's feeling a little short of breath right now. I'm not liking the way he's looking. I'm gonna go ahead and call a rapid, and I'll go ahead and call the primary team. Okay. Hey, I'm in 26. I have a rapid. Hi, this is Kiara. I'm in the patient room 926, Mr. Jones. Hey, I have a rapid. Can I get some help in here? Bring the monitor and someone come in here and take a look at him. We're calling the rapid response right now. Thank you.
They both use a standardized SBAR format: situation, background, assessment, and request to communicate their concerns of clinical deterioration. The bedside nurse calls the primary team while the charge nurse activates a rapid. The charge nurse also calls for help and a monitor. As personnel respond, she will designate roles and responsibilities.
He's already on telemetry. All right. Let's get his pulse ups.
The rapid response nurse and respiratory therapist arrive within minutes to conduct a primary survey while receiving an updated SBAR report.
Hi, I'm Brittany, the rapid response nurse. This is Jamie, the respiratory therapist. Can you tell me what's going on? Yes, this is Mr. Jones. He came in last night with significant exacerbation. I came in just this morning and checked him. His systolic was in the low 80s, which is a significant change from this morning, and his SAT abnormal to the 80s. Take a listen, Joe. Mr. Jones, can you take a deep breath for me? Mr. Jones? Mr. Jones? It doesn't look like he's responding.
His pulse is actually pretty thready. Mr. Jones? Hey, bud. Mr. Jones?
Let's go ahead and activate. You follow code?
Calling a call.
The patient's condition deteriorates and the code team is activated.
26.
CPR should be initiated within 1 minute of the patient becoming unresponsive. Remember your priorities. Compressions come first, then airway and breathing. Compressions should not be halted for more than 10 seconds at any point during resuscitation, such as when pads are placed in the anterior-posterior position.
All right, on count of 3, we're going to turn towards you. 1, 2, 3. Okay, lay them flat. Resume compressions.
End-tidal CO2 monitoring is added to the AMBU
All right,
bag
let's go ahead and add the end-tidal CO2.
to allow for goal-directed resuscitation. End-tidal CO2 and see-through CPR can be used to avoid pulse check interruptions.
Let's analyze the rhythm.
Rate, depth, and recoil with compressions can be assessed using enhanced defibrillator feedback technology.
Hold compressions.
Analyzing.
The rapid response nurse uses the analyze function
Shock advised. Staying clear.
to determine if a shock is needed until the code physician arrives.
Shock delivered. Resume CPR.
Defibrillation needs to occur within 2 minutes of identification of a shockable rhythm. Now that the rapid is shifted to a code, roles and responsibilities for those in the room also shift. The rapid response nurse leads the code and coordinates the critical care personnel by name, which include anesthesia, critical care physicians, and critical care nurses. The charge nurse coordinates local responders by name, which include the reporter, who uses a computer or portable device for documentation, security for crowd control, runners for additional supplies, and the chaplain who is there for the family. Bed management occurs outside the room by the ICU charge nurse, patient flow coordinator, and house supervisor. When the code team arrives, the rapid response nurse gives an SBAR report to the code physician, and the code is run according to the patient's clinical condition.
Hey, Dr. Khanum, the code RN. We just shocked him at 150 for a VFib arrest. He looks to still be in VFib. The last shock was delivered a minute and a half ago.
Thank you, Brittany. Have we given any meds yet?
No meds yet. We do have IV access.
Let's give epi.
Notice the closed loop communication, which is critical during a code.
Good compressions.
1 milligram of epi in.
Looks like we have a good airway and you're ventilating.
At pulse check, we're going to switch compressors.
Looks like it's VFib. Let's go ahead and shock.
Charging at 200 joules. Everybody seeing clear? Shocking. Shock delivered. Resume CPR.
Resume compressions. Ten seconds till pulse check. Pulse check.
Has a pulse with compressions.
Hold compressions.
We have a pulse. Good job, guys. Let's secure the airway. Let's call the ICU.
If there were a code on your floor today, would you know what to do? Work with your team until everyone on your unit knows their roles and responsibilities so that we can change and save more lives.
Oh, di ba nakita nyo, synchronize silang lahat. Lahat sila, alam nila kung anong gagawin. Okay? Now, dito sa atin kasi, hindi ko sure kung paano ang sistema ng Code Blue, pero kung nakapag-experience kayo ng Code Blue sa hospital, pwede nyo siguro ikwento ang experience nyo kung paano. May mga ano ba, may protocol ba, may system ba, o basta na lang kung ano yung walang exchange. Kasi usually talaga, ikaw ang naka-discover, ikaw ang nurse ikaw naka-discover. So, tatawag ka ngayon, ang sistema is tatawag ka ng Code Blue. So, dito sa kanila, tatawag muna ng rapid, okay, to assess, to further assess the respiration and the cardiac situation and things like that. Kapag hindi nila nakaya yan, ibig sabihin, kailangan talaga i-Code Blue sa patient. Saka ngayon dadating ang Code Blue team. Okay, yung mga naka-blue kasama ang doktor. So, once may proper response from the nurse, from the rapid, and from the Code Blue team, ay talagang masusurvive si patient. Pero kung walang proper coordination, yung crash cart hindi puno ng gamot or walang gamot o expire yung gamot or things like that. Tapos yung defib hindi na-charge, so hindi makapagtrabaho ng maayos. So, disorganized. So, talagang mabubuhay si patient. Hindi talaga mabubuhay si patient sa ganon. So, properly organized yan pati sa mga gamit, sa mga gamot, at saka sa action ng kada members of the ER team. Okay? So, ayun. So, let's move on. Now, sa adult basic and advanced life support, meron tayong guidelines na binigay ng na ama, ng AHA pala. So itong mga latest na ito na yung 2020. Okay? Ito yung mga binigay. So far naman, ano tayo ngayon? 2024. Wala pa naman silang latest na binibigay. Hopefully by sa 28, kung for example, meron silang important or what do you call this, update na na ang tungkol sa sa cardiac station from the American Heart Association. So at least updated tayo. Okay? So ito ang guideline nila on recognition of a cardiac arrest event. A nurse or layperson should simultaneously and properly activate the emergency response and initiate cardiopulmonary resuscitation. This is, for example, makita mo nga na pulseless na. Pero yung patient natin kanina sa video, nagsalita pa. So may pulse pa talaga. So pero kapag pulseless na, walang breathing, immediately you have to initiate the CPR. Performance of high quality CPR, adequate compression, na kapag nagsi-CPR, straight yung niya, braso niya. The shoulder is perpendicular to kung saan na nakalagay ang mga kamay niya. Okay? Compression depth, nakita nyo, 1 to 2, 1 to 1.5 pagbaba, 1.5 to 2 pag adult, di ba? And the rate while maintaining poses in compress. As much as possible, compression should be continuous. You can use for purposes of like, for example, kagaya ng nilagay yung monitoring pads code niya. Okay? O kaya kapag nag-intubate siya, intubate na, yan, nilagay ng defib. Binigyan ng defib. Okay? So next, early defibrillation with concurrent high-quality CPR is critical to survival. So kung early defib, like for example, isang cycle ka na ng CPR, tapos pangalawang cycle, monitor yan kung meron ng pulse o hindi, kung ano na ang nasa monitor, nasa screen, kung okay ba siya o hindi. So kung wala, bibigyan na kagad ng shock. Okay? Yung shock, ibig sabihin yun yung electrical shock, yung defib. Okay? Early defib, mas nakaka-regulate ka agad. Kung gulatin po sa, uy, ano yun? Tapos ayan na, mag-regulate siya. So kung elder plus high quality CPR, ano ibig sabihin ng high quality CPR? Ibig sabihin nun, nakakapag-produce or nakakapag-supply ng adequate dugo papunta sa brain. Okay? And administration of epinephrine can carry high quality CPR improve survival, particularly in patients who are who have cardiac rhythms that are not non-shockable. Okay? Ano-anong mga non-shockable rhythm? VTAC is shockable. Severe bradycardia is shockable. Tachycardia medyo hindi pa, pero kung over ang pagka-tachycardia, umaabot na siya 120, 130, kailangan na siya i-shock. Okay? Ayun. So recognition that all cardiac arrest events are not identical is critical talaga. Lahat ng cardiac arrest, iba-iba. Kasi iba-ibang tao yan eh. Okay? So, kung ganyan ang tingin natin, iba-iba, so we are going to deliver an individualized kind of CPR care sa patient. And that is also important to get an optimal patient outcome. Okay? So, kailangan na talaga after mo na shock, after nakita mo na may pulse, may heart rate na, treat mo na kung ano pang mga underlying causes, underlying disturbance ni patient. Okay? The opioid epidemic has resulted in an increase in opioid-associated out-of-hospital cardiac arrest. Alam niyo ba ano ibig sabihin ng opioid epidemic? So, nangyari kasi ito na yung sa US, sobra kasi daming nawala ng bahay, lalo na nung pandemic. Alam niyo naman, nung pandemic, ang daming na business, ang daming nawala ng trabaho. Doon kasi sa kanila, madali sila kumuha ng bahay, madali sila mag-loan ng bahay. Pero kapag hindi mo yan bayaran, evicted ka talaga. Hindi ka na pwede dyan. So marami talaga sa kanila nakatira sa street, sa tent, sa mga ganyan. So isipin mo, yung pagtira nila sa mga street, sa mga park, sa mga ang kotse nila, ginagawa nilang bahay. Kapag winter time, sobra talagang lamig. So paano sila ma-shield yung mga katawan nila? Kung for example, ilagay natin puro jacket, gaano ka doble diyan. Pero hindi pa rin talaga kaya kasi bukas ang mukha mo, ang ilong mo, ang pagsinghot mo ng hangin, yung mga paa mo. So marami talaga. So they resorted to mga opioid, tawag dito, yung mga injectable medications na pampa-addict, yung parang maano sila, parang maging strong sila sa lamig na yan. So nagkaroon ng opioid epidemic. At because of that, ang dami din nangyari ng mga cardiac arrest sa mga streets. The reason why kaya nagkaroon ng mga AED sa mga located area sa US na kung for example may cardiac arrest, pwede lang kunin yung AED, gamitin ka agad kay patient. Meron silang mga ganyang sistema na. Okay? Ayun. And post-cardiac arrest care is a critical component of the chain of survival and demands a comprehensive structured. Yung chain of survival, ang importante dyan is yung time. Okay? Early detection, early implementation. Ayan, talagang makaka-survive. Okay? Next. Prompt initiation of targeted temperature management is necessary for all patients who do not follow commands after return to spontaneous circulation. Alam mo, meron silang time na i-hypothermic period si patient, okay? After resuscitation. Nakalimutan ko kung ano ang meaning nito. Kailangan talaga i-hypothermia si patient. Meron siyang meaning okay? But this is also one tool to determine ang mga physiological and neurological function niya. Okay? So, acute neurological prognostication in brain-injured cardiac arrest survivor is critical. So, ano ang dapat gawin? Aside from GTS, meron tayong cognition tool, meron tayong mga tools para malaman natin kung meron ba talagang brain injury or none. Okay? Maliban lang yung malalaman na lang natin massive stroke na pala siya. Okay? Kasi most of these patients are comatose. Most of these patients are not responsive. Kahit nasabihin mo na-revive na siya, they tend to be sleepy. So baka naman, sabi natin, pagod lang yan, ganun-ganun. Yung pala, neurologically deficient na pala siya. Okay? So, kailangan critical ang mga assessment natin dyan. Recovery expectations and survivorship plans that address treatment, surveillance, and rehabilitation need to be provided to cardiac arrest survivors. Ayun. So, sa sistema na ito, kumbaga, yung mga survivors talagang makakabalik talaga sila as normal. Not necessarily normal talaga, pero because of the provisions of the needs na kailangan niya for rehabilitation, for survival, talagang masisave talaga si patient. Okay? So ito, guidelines para sa atin, binigay ng American Heart Association. Ito yung pinaka-updated. Pero ito lang mga pinag-aralan nila na tawag nito, mga process ng like for example CPR, dapat pa ganito. Okay, after how many minutes kailangan ba natin bigyan ng ng epinephrine kaagad? So ito yung dito mga highlights, okay? At meron din dito naka-indicate kung paano ka mag-save ng pediatric sa street o kaya sa hospital. So meron siyang mga guidelines diyan na nilalagay. Bakit ito lang ang binigay ko, hindi yung lahat, hindi yung inisa-isa ko na, kasi ang haba niya eh. Basahin nyo na lang. Okay? So you can read this also so that you will be prepared naman to be conversant, to be interactive doon sa 28 na training na sinasabi. Okay? Ayan. And that ends our topic. Meron question? Yes, Jancel.
Ma'am, dun sa resuscitation po during emergency, ano po ma'am, yung sa patient, kailangan ba ng ano ma'am, yung order ni doc or ng
Ay,
physician
hindi.
po sa ano?
Hindi. Kapag may walang pulse, kailangan mo na mag-initiate ng ng cardiac compression. You do not need to wait for the doctor. Kailangan immediately, ikaw pa mismo yan mag-initiate na. Kunyari sa hospital ka, nakita mo pulseless yung pasyente mo.
Yes po.
Lalabas
Pero
ka agad, sisigaw ka lang, lalabas ka sa room, sisigaw ka, code blue. So, code blue, room ganito. Tapos balik ka ulit sa patient, initiate mo na kaagad ang cardiac compression. Kasi ang pinaka-goal natin is do not deprive of oxygenated blood into the brain.
yes.
Yun ang pinaka-goal natin. So,
Pero
hindi
yung
natin, sige.
Pero
Ano?
yung fluid resuscitation po ma'am in terms of yung sa ano po, yung blood products po ma'am.
Sa fluid resuscitation naman, what do you mean? Pag dumating si patient sa ER, ganon, tapos alam mo na hypovolemic and things like that. Yes, kasi ER nurse ka eh. Pwede ka, hindi mo kailangan ng doctor's order. And then, for example, pagdating ni doctor, saka mo na ibigay, saka na niya isulat yan because you are doing the right thing. May protocol yan. Kapag sa ER, may mga protocol yan. So kahit walang order, pwede mo nang simulan. Pagkatapos nasimulan mo na, si doctor naman, ang mangyayari sa kanya, kasi most of the time, medical documentation sila, so dagdag na yan sa charting nila, dagdag na yan sa order nila, kasi protocol na yan. Ibig sabihin ng protocol, nandyan na nakaset ang step na dapat mong gawin. Pag may dumating na ganito, ito ang una nating gawin. So, protocol na yan, no need to write the doctor's order. Kapag okay na, i-document na yan ni doctor within that time also, bago i-transfer si patient. So, ganun.
Yes.
Ay, meron pala akong ipapakita sa inyo, yung CPR. Ewan ko kung pinakita sa inyo yung, kasi shinare ko ito sa mga CI. Check lang ha. Ewan ko, mahanap ko ba yun? Ayan. Ang ganda niya and it makes us understand well sa sa gagawin natin. Wait lang, share ko sa inyo. Para maintindihan niyo talaga yung compression. Nandiyan na ba? Ay, bakit can't share the screen? Can't share your screen? Bakit? Wait lang. Bakit kaya?
Itong save station po ba ma'am?
Oo. Meron ba kayo nun?
Ay nakikita lang po sa screen. Yun, nawala.
Wala, bakit kaya? Ano kaya ang problema? Sorry, an error has occurred when... Bakit kaya yun? Wait lang ha, ulit. Kasi, diyan nakikita kung bakit importante yung depth ng compression. Okay.
Our heart is an amazing organ. It works hard for us every second of every day, delivering blood and oxygen to every cell in our body. But when sudden cardiac arrest strikes, our heart suddenly and unexpectedly stops beating effectively and blood flow stops. Without any intervention, the brain, vital organs, and our heart will begin to die. Beginning CPR is the person's only chance of survival. Brain damage will start to set in within 4 minutes, and after 10 minutes, brain damage becomes irreversible. Power to save a life is truly in your hands. Performing CPR accomplishes 2 critical things. 1, compressions move oxygenated blood to the brain to keep the brain alive. And 2, compressions keep blood and oxygen moving to the heart muscle itself, so that it has the best chance of resuming a normal electrical rhythm after a shock is delivered. As you begin compressions, you are creating an artificial pump doing the work of the heart manually. With each good, effective compression, we're building up pressure in the system, which will move blood around the heart and up to the brain. It does take time to get the blood moving with CPR, so it is very important to push hard and push fast to build the pressure up, which keeps blood going to the brain. Pushing down at least 2 inches allows for the heart to be squeezed and blood to move out. Pushing at a rate of 100 to 120 compressions per minute is necessary to keep blood pumping. Let's see what happens when we take our hands off the chest. Blood stops moving to the brain. It is for this reason that if you are taking your hands off the chest to deliver breaths or switching roles, it is critical to minimize time off the chest. Watch what happens if we don't push deep enough. Blood does not reach the brain. The same is true if we do not push fast enough. Watch what happens when we push too fast. The heart does not have time to refill with blood. Therefore, not enough blood gets pumped out. Watch what happens when we don't allow the body to decompress and allow the chest to fully recoil. The heart does not have a chance to refill with blood. Therefore, no blood gets pumped out. So remember, the key purpose of delivering compressions is to keep oxygenated blood moving within the heart and up to the brain to keep the brain alive. We need to push hard and push fast in the center of the chest. If ribs break, that's okay. What's not okay is allowing the brain to die from a lack of oxygen. So remember, you are their only hope. Do the best you can and don't give up until medical help arrives or an AED is present. You can do it.
Okay. Okay, so ayan. So napaka-importante talaga ang what do you call this? Napaka-importante talaga ang proper or adequate and correct cardiac compression. So nakita nyo na, hindi umaabot ang dugo sa brain kapag hindi tama ang compression. So always follow the correct procedure when compressing. Okay, ang sabi niya, if a rib is broken or may mga fractured rib, walang problema. Ang importante, ipaabot natin ang dugo sa brain. Okay? Yung fractured rib, pwede yun i-treat mamaya or later kapag stable na si pasyente. Okay? Meron talaga ganyan. May instances lalo na kapag ang kina-cardiac arrest natin ay mga matatanda. Brittle na kasi ang mga bones nila. Okay? May question pa. Wala nang question? Yes, Jansen.
Ay, napindot lang po, ma'am. Pero yung sa ano po, ma'am, fractured rib, pabayaan lang rin po ba, ma'am?
During emergency, hindi muna siya ang priority. Once na-stabilize na si patient, pwede na siyang asikasuhin. Okay, ang ano lang naman doon is to check kung anong klaseng fracture nangyari kay patient. Kapag ang fracture is parang crack lang, okay, so immobilization lang ang kailangan ni patient, okay? Lalo na kapag tineturn siya, kailangan doble ingat, yung mga ganyan lang. And then the bone itself will heal by itself. So promote wound healing, bone healing lang. Alam natin pag matatanda, matagal ang healing. So ayan na, marami na tayong mga kailangan, may mga nutritious food at chuchu, ganon. Pero kapag adult yan, walang problema kasi the healing will take about a month lang. Okay, a month or two, healed na yan. Ang priority natin ngayon kapag is the oxygenated brain. So, kung for example, na broken yung ribs niya, sige lang, ito take care natin yan after. Okay? So, ayun. So, kahit nasabihin mo, masakit yun, di ba? Masakit yun yan ang gagawin, stop ka ba? O di, wala, stop na rin, pati yung pag-oxygenize ng brain, wala na rin mangyayari kay patient. Dahil lang, iniisip natin na masakit yun pag kinocompress natin. O prioritize mo yung masakit. Eh di, wala na si patient. Di ba? Ayun.
Paano po pag fragmented yung ribs?
Ano yun, Daryl?
Ma'am, fragmented na. Halimbawa, sira-sira na. Hindi ba kaya, ma'am, magkaroon ng lacerations towards the
Ang ribs natin, may mga joints din yan. Okay? Meron siyang mga cartilage and tendons. So, kapag nagko-compress tayo, parang cushion lang din siya. But, kapag sobra ang pressure na binigay natin plus osteoporotic si patient, pwede siya ma-fracture. But not necessarily to be like, for example, fragmented or yung tinatawag natin na comminuted fracture, nadurog yung buto. Hindi naman pwedeng ganon when it comes to compression lang. So when it comes to compression, most probably ang mangyayari is parang crack ng ribs, yung ganon, crack lang ng ribs. But kapag ito ay osteoporotic, pwedeng mahiwa talaga ang ribs. So pwedeng masabi natin na complete compound fracture and things like that, but not necessarily comminuted or yung durog. Okay? Not necessarily. Along our discussion dito, in some weeks, di-discuss din natin yung mga different kinds of fractures. Okay? So, leave it there kasi meron tayong ibang topic dyan. Pero again, priority natin when doing CPR is yung oxygenized brain. Nag-CPR kayo sa adult? Nag-CPR ba kayo sa pediatrics? Nag-RED-DEM kayo sa pediatric CPR?
Hindi po, ma'am.
Hindi po.
Ano ang ginagamit kapag CPR ng bata?
Yung fingers lang po ba, ma'am?
Okay, daliri lang. Pero kapag toddler and above, mga 5 years old, 6, yung palm, isang palm lang. Pag adult na or teenager na, dalawang palms na. Okay? At meron specific, may specific na lalim, okay? 1/2 to 1 ang mga maliliit. Tapos, yung 1 to 1/2 yung mga pediatrics, and then 1/2 to 2 yung malalaki. Okay? Meron pa? Sa na kayo magtanong sa mag-CCPR kasi sayang yung babayaran natin sa kanila. May bayad daw yun. Hindi ko lang sure kung magkano. Kasi kami, mag-a-attend din kami, magbabayad din kami. Yes, kayo, Bit. Hmm. Hindi, aayusin yan kasi ayusin yan. Magmi-meeting kami mamaya. Tapos bukas magmi-meeting din kami with Dean. So, after that, ilabas na yung announcement. Okay? Oo. Okay. Okay.
Ma'am
Sige.
Jan, ay sorry po.
Magkano
Ma'am Jan,
sorry, magkano daw? Okay. Kasi magbabayad din kami, magjo-join din kami, magbabayad din kami. Okay. Yes, Jancel, ano yun?
Ma'am Jan po sa preferred date, ma'am, pwede po ba uniform preferred date yung sa 4th year po? Kung ano po, ma'am.
What do you mean? Uniform
For
preferred?
example, ma'am, sa 30, ganun po. Hindi po sa 28.
Depende kung hindi. Kasi ano yan eh. Kung sino pwede accommodate kasi priority ang mga 4th year. So, pipili kayo kung anong gusto nyo. Kung lahat ng section nyo gusto nyo ng 28, sige sa 28. Kasi the area can accommodate naman marami. So, walang problema.
Ma'am, ano po yun? 1 day lang?
1 day lang, pero 3 araw to para iba-iba ang iba-iba ang a-attend. Ayun. Yan ang pagkaalam ko ha, pero alamin ko rin kung 3 days, ano yun? Ang dami naman nun. Di ba? So, ibig sabihin, ano yun? Kaya nga, oo. Kasi kung 3 days ang pinaka-training, ano yun? CPR lang naman ang anuhin natin, di ba? So, that is also for the distribution ng mga estudyante. And it will be the first dito sa batch nyo, pero continue na yan next year. Same pa rin. Sa iba na naman. Graduate na kayo nun, di ba? So yung 3rd year, kaya nga priority ang 4th year kasi ang 3rd year meron pang choice for next year. Okay? Tapos kung sino pa ang susunod, ayun. Priority ngayon 4th. Pero kung pwede sumali ang 3rd year, good. Maganda din. Okay, Dukes? O, ano pa? Sige. After the meeting. Meeting mamaya plus meeting bukas and then update na yan sa inyo. Through the council na lang kasi wala akong ibang way para mag-connect. Dati kasi kasama ako sa mga patient representative. Pero nabago na kasi ang sistema. Yung masyadong maingay ang GC ng ng class representative kasi syempre ang daming concern ng mga estudyante. So lahat ng concerns kinukuha na ng council tapos binabato na lang sa amin or kung kinong concern. Kung sa first year coordinator, kung sa second sa level 2 coordinator, yung mga ganyan. Ganun ang ginagawa. Kung sa akin, ganun. Okay? Meron pa ba? May questions pa? So, kung wala ng question, you can go now. Bye! See you next meeting.
Thank you po, ma'am.
Thank you po, ma'am. Thank you po, ma'am. Thank you po,
Yes,
ma'am.
i-upload ko ang PowerPoint.
Thank you po, ma'am.
I-upload ko itong PowerPoint.
Thank you po, ma'am.
Okay, bye-bye.